Joint Secretary of the Ministry of Health and Population, Dr. Guna, my colleague, to say a few words before we start the presentation.
Thank you, Professor Prakash Kimire. I'm very much honored to be here to chair with Professor Gimire in this very important session on AI, health technology, and innovation. So we have 2 hours from now, and we have invited speakers and presenters in different area of research and evidence, and we will have very good discussion as well. And for some few housekeeping notes, we have already allocated 10-minute times for each of the presenters, but some of the presenters have a bit leverage to have more than 10 minutes that we have already informed the specific individual presenters here. So without further delay, let me invite the first presenter. The first presentation will be an AI policy for healthcare. We are pleased to invite Professor Dr. Shruti Patil, who has over 14 years of experience spanning academia and industry, and she currently serves as professor and director of the Symbiosis Artificial Intelligence Institute in Pune, India. She was a recipient of Young Leader in AI-Driven Education Award, World Education Summit 2024, and recognized among the top 5 women researchers and Symbiosis Sprinter Nature 2024. Welcome, Professor Shruti Patil. Now, floor is yours.
Yeah.
Over to you.
Thank you so much, and a very warm thanks to all the organizers and for the invite given to me. And I'm Dr. Shruti. I'm heading the Symbiosis Artificial Intelligence Institute at Symbiosis International University, Pune. And along with that, I also work as a research associate with Symbiosis Research Lab as well from last 6 years. The topic which is given to me is about health and technology, and giving a glimpse about the policies of AI that can be implemented here as well, and the loopholes which are present, and the kind of AI advances which are going on currently in healthcare. Yeah, so if we see the technological advances which are going on currently in AI, we have started with classical machine learning. From there, since there was a huge volume of data which came into the picture, we moved towards deep learning. From deep learning, we move ahead towards self-attention networks, and transformers came into the picture. From transformers, now we have reached till generative AI, where AI is not only able to analyze the historical data, but it is also able to generate new data as well. So the invent of that started with large language models. From that, now we have reached till AI agents and agentic AI, where we said that why AI is only generating the content, can AI help us to even automate our task? Right? So LLMs are basically at the heart of agentic AI, where LLM can decide the entire task and the task can be executed by AI agents. Now, this phenomenon has created immense amount of automation in the healthcare sector. So even in India now we do have a technological assistant with the doctors who are helping them with automation of their documentation, automation of all the clinical document, structured data processing, automation in patient monitoring, also lots of automation in hospital management, as well as very deeper research on new disease prediction, or we can say new drug discovery also. So AI is not only helping in disease detection, but AI is also helping in disease prevention. It is also helping in patient monitoring. It is also helping in hospital management, also helping in resource management. So each and every life cycle of medical facility, AI is helping to automate in India. Now, if we see the global landscape, AI in healthcare sector is growing at a very, very alarming speed, where we now not only have prototypes of healthcare applications ready, but now they have pushed to production. So many of the applications in robotic surgery, in patient management, in I would say disease prediction, not only the pilots are ready, but they are already in production. The doctors are already using it. The hospital management is also using AI enabled softwares here. Also, physician AI adoption rate has increased till 66%. So before few years, there was lots of resistance from the doctors to use AI. Now that resistance have changed. Now not only doctors, but the support staff such as nurses, they are also adopting AI at a very, very faster rate, which is definitely helping in a country like India, where there is huge volumes of patients in each and every hospitals. From their clinical accuracy have also increased. So with the advent of large language models, now you see, especially the most recent one, which is named as Claude is giving very good, what I would say, analysis of the medical reports, which can be considered as the second opinion along with the first opinion with doctors. That is the kind of accuracy which AI tools have already achieved. And last one is the governance imperative. So definitely now the government is taking lots of efforts in skilling the doctors, in skilling the nurses, in also giving lots of funds to various startups which are in healthcare. So there are special subsidiary rates which are given to all the startups who are working on AI plus healthcare, because a digital workforce is getting ready in India for healthcare management, along with the human workforce which we have. And similar kind of strategy each and every country now is moving forward to. So if you see where AI actually delivers value today to us in healthcare sector, so there are two differentiation to that. One is the clinical and public health, and another is the system and operations. Especially in clinical and public health, if you see advent of AI tools, integration of AI tools into the processes, definitely it is adding lots of value there. The diagnostic accuracy is also improving. Since we have a very good diagnostic accuracy, so it is also fostering the telemedicine kind of applications a lot, where in the rural areas where there are no doctors, but now there are AI kiosks which are set up, where the vital analysis can be done and the doctor can be connected online with some of the city hospitals, and that way the expertise of such kind of doctors who are staying in the cities is also getting reached till rural areas of India, which is getting possible with the help of diagnostic accuracy. And 100% adoption rate is there for clinical documentation. So the amount of documentation that happens in the hospital, which has to be done by the doctors or by the nurses or by the insurance companies in order to give the insurance to the patient, everything is getting automated with the help of AI tools and softwares. When you see on the system and operation sides, it is inventory management, patient management, resource management, beds management, ICU management. These are the areas where AI is definitely delivering a lot of value. Yeah. Now, critical AI technological advances which are really helpful in the healthcare sector. The first one, if we see, are multimodal foundational models. Now, we do not need to have chat gpt for text generation and then another foundational model for image generation or audio or a video generation. With the help of new foundational models such as Claude, we can do everything using one tool, right? Which means multiple modalities, be it image, be it audio, be it text, be it document, be it pdf, be it video, can be generated by one large language model tool itself. So that is known as multimodal foundational models, which means now we will not have chat gpt which will only generate text. We will have such kind of tools which will be able to generate any modality kind of output. Next is the agentic AI in clinical workflows. Now, as we have seen that for automation of every task, there can be an AI agent. So if you see various kind of applications such as GenSpark, or for example Claude, or for example Perplexity, so what all of them are doing, whatever task we are giving to them, they are converting it into a task given to an AI agent, right? Now, in our day to day life, we do not work based on one task. At one point of time, we do n number of different tasks, which means that for n number of different tasks, we will have n number of different AI agents, right? Which will work together to simulate the environment in which we are working. So that phenomenon is known as agentic AI. So for any kind of clinical workflows which we have, right from patient coming to the hospital till the patient going home and again taking follow-ups of the patient, everything can be automated with agentic AI. Right. Another is federated learning and privacy, because now we do not have one hospital at one place. We have hospital chains which are located at different locations. Some hospitals are in city areas, some hospitals are in rural areas. So that is known as federated learning, which means distributed learning. Still every hospital will be connected to one server where there will be AI analysis done, and in this way the data from all the hospitals can be collated centrally, as well as all the analysis of AI can be done centrally, right? Another is AI powered drug discovery, very apt application of AI, where there is immense amount of scope where AI can be used for drug discovery. Another is digital pathology and ambient clinical intelligence. The moment the patient enters into the hospital, all the lab test which has been conducted, everything is stored into digital servers, and AI will keep predicting that, what kind of diagnosis the patient has, which kind of doctor is allocated, what that doctor has given as what we can say, the medicine journey of that patient, the kind of symptoms, and what is happening when he is returning back home. The entire life cycle of the patient can be monitored, it can be analyzed. Next time when similar kind of patients are coming, initial first line of prescription can be done using AI itself. That is known as the power of digital pathology. Immense amount of our vitals data is currently lying into hard copy lab reports, right? We are not doing anything of those lab reports. So that is where AI is playing a huge amount of role. So this transition we have definitely seen. So given the paucity of time, I would skip this particular slide. We have seen generative AI, AI agents, and agentic AI. Now, the current digital health transformation which is currently going on in Nepal, if we see the foundations where telehealth currently is achieved at 20%, but EMR is achieved at around again 20%. Mobile health is something which Nepal is doing very well as compared to telehealth and EMR automation. Now, the emerging implementations that can go is imaging AI pilots, or chatbots can also be developed, and chatbots can be given as supportive technology to lots of patients for managing them, and predictive analytics on the existing data, because lots of communicable and non-communicable diseases and pandemic kind of diseases are coming into the picture. So in that case, predictive analytics will play a very major role here. Along with this, there are definitely some work in Nepal which is going on in these three areas as well, where there is a growing ecosystem in Nepal. The awareness about AI is definitely increasing a lot. Initial policy dialogues have also started, because it will have lots of AI patients data. So what kind of data privacy we have to maintain if we are implementing AI for healthcare applications. And last one is the evolution and scale up. Can we implement AI only for one hospital? We can't, right? We have to implement it across all the hospitals, maybe for millions of patients in Nepal. So how these AI enabled applications can be scaled up is also something where the work has started in Nepal. So if we see, based on the WHO 2026 global TB report, 71 is the year life expectancy here in Nepal. Maximum mortality is happening by NCD, which is non-communicable disease. Because of that reason, maximum mortality is there. By communicable disease, there is only 20% of mortality which is currently happening. And in healthcare workforce, if you see, the workforce of doctors is very less as compared to the workforce of nurses and midwives. So that is where again we have to provide a technological support to doctors also and to nurses also in Nepal. So now, what are the public health challenges generally here which are seen are non-communicable diseases, where is diabetes prediction, or CVD, which is related to kidney disease, or cancer screening. In climate change and health, again we are able to see that air quality alerts definitely is one of the area. In pandemic management, it is about contact tracing or early detection systems. And in public health surveillance, epidemic forecasting is something which is very, very important. And AI is proving very effective in this case. Population health monitoring or social analysis are the areas where AI is going to play a very, very major role. Now, what are the high impact use cases in this case? Definitely diabetic retinopathy, or TB CXR triage, or AI to analyze infant cry in various rural areas. Based on that, if we can analyze what is happening to infants, then cervical cancer, pediatric pneumonia, or sepsis early warning, these all are the areas where AI has already proven a very good accuracy, and these can be definitely very easily adopted for Nepal patients' data as well. Now, especially since morning I'm listening, lots of emphasis is given towards pandemic preparation at Nepal. So during COVID-19, what AI has delivered? AI has delivered us a genomic surveillance. It has helped us in drug repurposing. It has also helped us in CT scan analysis. So all the COVID cough patients which we had, so the analysis of their scans we were able to do using AI. And epidemic forecasting also we had done during COVID-19. Now, if any next pandemic comes, what AI can do apart from these things? So AI can definitely be used for agnostic model development. It can, where our model is already trained on COVID-19 data now. We had lots of data of COVID-19. So definitely AI can be used for pathogen agnostic model development. It can be used for wastewater epidemiology AI. Supply chain optimization, which was biggest issue during COVID-19, especially in India, where the vaccines were not reaching to the rural places and there was too much chaos regarding the supply chain of those vaccines. That can be very easily optimized now. And also infodemic management, because during COVID there was immense amount of misinformation on the entire social media, and it was very difficult to manage what is true and what is misinformation. So even that management now can be very well done using AI. Even for climate change, public health, and AI in Nepal, AI can help in flood and disaster management. It can help in management of waterborne and vector diseases such as dengue. It can also help in extreme heat and NCD related diseases. It can help in analyzing the air quality, food and malnutrition, as well as One Health and zoonosis as well. AI can play a very good role, and in all these areas also currently we have such kind of AI models who have proven a good accuracy. Maybe just 2 minutes more. So AI in communicable diseases, especially for Nepal relevant evidences, if we have, these are the areas where definitely AI can play a major role. Well, we have seen dengue and malaria, but for respiratory diseases, because there is air pollution alert which has increased in Nepal as well. So similar to India, here also there might be many respiratory related diseases where management of those diseases can also be done using AI. So the global policy frameworks which are already available is main this EU AI Act is there, or US FDA AIML action plan is also available. And for AI Nepal policy, we can see the strengths, but the gap in the governance node, there is no risk classification which is currently done, and the opportunity where we have to go phase-wise implementation of AI. It cannot be centralized implementation of AI. It has to be distributed for small applications of AI which has to be developed, and then those applications have to be integrated into one holistic healthcare application of Nepal. So the key pillars can be governance, human capital development, definitely required, and even India is paying lots of attention to that. Immense amount of efforts in research and innovation is required. Public-private partnerships are definitely required for AI. We cannot work in silos that, public universities or organizations are working separately and private ones are working separately. There has to be an integration between these organizations. And rights and data security, because it is going to be country data, and lots of countries now are coming ahead with sovereign AI, where they are saying that the data which is used for training of those models will be inside the country itself. So the data centers, the data servers will be inside the country itself. So those kind of rules also needs to be thought of. So ethical AI policy, very important if we want to implement it in healthcare. So we have to see the biasness in the data. If it is there, we have all the data from city patients, but no data from rural area patients. Of course, it will introduce a bias. If we have all male data in the system, but very few female data in the system, again, it will introduce lots of bias. So we have to take care that whichever applications that we are developing, all those applications should be free from bias. Explainable AI should be there, otherwise doctors would not understand why AI is giving these kind of predictions, right? Procurement integrity, equity in access. Quickly, I will rush through because my time is up. Yeah, this is a very important slide where we can do a phased implementation of AI in the healthcare sector, where we have to start first with governance foundation, then we have to move towards implementation of pilot prototypes and also studying the governance, and from there we have to scale and then research. So these slides I would be sharing with all of you, so all of you can use it for reference as well, because I have prepared especially for this summit. And 5 critical takeaways here is everyone has to work in sync, be it clinicians, be it policymakers, be it public health leaders, researchers, and digital health implementation. All these stakeholders have to work together and then implement one system as a whole. It cannot be separate, integration of AI that will help for a brighter future here in the healthcare sector of Nepal. And with this, I would like to finish my presentation, and thank you. Yeah.
Thank you. Thank you. Thank you, Dr. Shruti, for your enlightening presentation.
Thank you
So
so
you
much,
have
sir.
brought a very good business perspective of a model which is 45 billion the global market, as you are coming from Symbiosis Institute, which I personally know that it's a institute which people envy to go for MBA,
Yes.
making business.
Yes.
So thank you for your presentation. We'll take the questions for all presenters at the end of the session. So please be prepared, and there might be many questions because this is a new area.
Yes,
with
definitely would be
huge
happy
market.
to answer, sir. Thank you so
Thank you.
much.
Thank you. Please have a seat.
Thank you so much, Professor Dr. Sruti. Very exciting presentation. Now we would like to invite Dr. Bishesh Khanal. He is the founding director and research scientist at NAM2, Nepal, leading AI Research Institute. He completed his PhD in 2016 from INRIA, France, and then he spent 2 years as the postdoctoral researcher in King's College London and Imperial College London, UK. He is a co-founder and executive member and member of the National Young Academy of Nepal. Over to you, Dr. Vikas.
Thank you. I was told to prepare 20 minutes presentation. All right. Okay. Good afternoon, everyone. Yeah, I'm Bishesh, and I was given to talk about policies in Nepal, but I think for this audience, it's important to know what's going on in Nepal. So most of my talk will show what has been happening in Nepal and contributing to the global knowledge in the sector of health and AI. Apart from NAMI, I'm also advisor and adjunct professor in IIIT Hyderabad, where we're building a new center for digital technologies. So does this work? Back next. Okay. Just some disclaimers. Apart from giving some lectures, visiting lectures in Cambridge in UK and supervising PhD students around different countries, I have some equity holdings in some of the startups. The one that could be relevant is Terras, which is around healthcare, while others are not necessarily in healthcare. So with that very brief background, as they said, I did my PhD in Alzheimer's disease, modeling brain and simulation in France, and in master's, that's when I started getting into healthcare from my background in engineering and robotics, and then doing a postdoc in King's, where inside the hospital, in St. Thomas's Hospital, and Department of Computing of Imperial College London. So really at the intersection of computing and healthcare. But during this time, along with the friends, we envisioned building a center of excellence in Nepal to work in AI and its related fields, and that's why I resigned at King's and moved back in 2019 here to establish the Institute NAMI. Very briefly, I'll talk about NAMI, and then we'll go into how this leads to the health AI research that we are doing here, which we the Institute itself we founded as building how do you build centers of excellence in resource-constrained settings in countries like Nepal, not just Nepal, but we want to expand this to other countries as well. And the whole it's about building the ecosystem. So that means knowledge generation, scientific research, very important. We need to generate knowledge from our places, from our problems. Then it has to be disseminated. That's where our education outreach works, and the industry innovation, where the benefits of knowledge generation, and especially now with the AI technologies, as a nation, as countries, it should also benefit from the global market, where it should be able to produce the products in the industry, because for the technology to go to the society, typically it takes the industry route. And across all these cross sectors, policy governance is really important. So NAMI works on these fronts altogether, from helping drafting AI policies, research in AI, to very different fields. In scientific research, there are multiple research autonomous groups. Many of them are in healthcare, but then there are quite a few which are not necessarily in healthcare. I lead a group called Transforming Global Health with AI, but there are a few other groups that are led by other faculties. Many of them are based outside, but they are adjunct faculties. And then, but then they have active full-time staffs here in Nepal, and we work on many different topics. But many of these people work in some of the best labs around the world. And we published nearly 80 research articles, many of them first time ever from Nepal, most of them in top venues in AI and in the top journals, trained many staffs. And not just that, we've won some of the very competitive international challenges on hard problems around AI and healthcare. So with that background, today I'll talk briefly about resource constraint settings, what it means in countries like Nepal, and what we can do in health AI in these resource constraint settings, and finally a bit on trustworthy AI. And I hope this will give the picture of how the policies should be built for countries like Nepal, where we can truly leverage the potential, immense potential of AI while minimizing the harms it might have. Resource constraint settings can come in many different ways. One that is very common and we know well of is lack of experts. So lack of experts can happen in primary community health centers, in zonal hospitals, district hospitals, where we don't have enough of doctors, radiologists, or consultants, or so various health professionals. But there is also the other way around, especially in government tertiary hospitals, where people from all over the country come. It's highly overburdened because we have a huge number of patients, very few, we don't have enough doctors to really, or radiologists to go through all the things that come. So that's also it's a resource constraint. Another kind of resource constraints, lack of devices, so CT scans, MRIs, there are many different medical devices that are very important but not always available. Now in the current context of AI, more and more there will be lack of data, lack of internet, compute resources if AI services are being deployed in various systems, or the financial resources. Can you think of other kind of health resource constraint settings? Anyone? What could be other kind of resource constraints? Anyone? Yeah, infrastructure, financial, resources. That's true. Something sometimes people don't think about, but I really think is very important, is also lack of research and innovation. Because health system is about making population healthy, and one important part of it is the medical science advancing to know and understand our human body, our diseases. And there are many diseases which are much more important to our part of the world, but very limited research goes on if we look at the global. That's why you have neglected tropical disease, or these kind of terms get introduced in the global health world. And typically, most of the time, because of the resource constraints, we wait for someone else to do the research, figure that out, and then we solve. And this has to change, I think. And that's at the heart of what we say about having centers of excellence in low-middle income countries, is to work on these problems as a priority, with the urgency, with the excellence that is needed to solve these hard problems. And that's important in neglected diseases, in things that are more important, and also in AI. For example, ChatGPT, many of you might have used LLMs, ChatGPTs. It works fairly good with English, now starting to work a bit with Nepali, but then when we have many different languages, and these benefits of science, it's not accessible to many population, because it's not built for those people or for our people. So, and that's where we need to do more research and then build these things. So that's the context. Now let's see some examples from Nepal on the health resource constraints. I'll give, most of these examples will come from my group within NAMI, although there are other groups who have done a lot of work as well. I'll take few examples from other groups, but my group works around different kinds of data. Visual data, that's imaging, so different kinds of images, from smartphone images to MRI, CT scans, but also ultrasound, X-rays. Language data, so it can be chat, it can be social listening, for example, if people posting on social media about COVID, for example, if you for public health intelligence, so those kind of work, or genomics and EHR data. So for us, it's different forms of data, and we work with this to understand diseases or to help improve health service delivery. The themes, the way I put these as themes in the kind of research we do, what kind of problems we tackle, what kind of problems we want to solve. Most of the problems we solve are the things that we want to do. It's not like someone else give us this problem and we try to understand the real problems we have, and we try to tackle those. So on these themes, one is around preventative healthcare, around how do we empower general public for prevention and early detection of diseases. With the smartphones, you have a lot of data these days. Right. And the second, lot of our work is around broadening the scope of health services delivery in primary and community health centers. A lot of our work is on that, and I think, so we recently, a month ago, we are also a prospective global collaborating center for the World Health Organization in AI and health, where we are building research around these topics. we need to build technologies at times when interventions are not possible, and population-based. So let's go into examples. I think that would be clearer. So preventative, which sometimes we don't think of this as health service delivery, but I think it's a very important health problem, especially public health problem. Pesticides, extensive use of pesticides, especially in urban areas like Kathmandu. We don't know how much pesticide we are eating. And for government to have the regulations, to have consistent checks, they could do better, but then there's infrastructural challenges, expensive devices, spectrometers. What if you could go to the pharmacy, bring a solution, bring a small kit, and then test right there in your kitchen? And this would empower the public, and that's what in partnership with Kathmandu Institute of Applied Sciences, who are from the chemistry, and so they built the kit, and then we work on building the AI models that would detect and say, okay, it's low, medium, or high concentration of pesticides. We did the first validation. We published a couple of papers, and we're planning to do a much larger validation. So that's one example of trying to empower public on the preventative healthcare. Let's see a few examples on the broadening the scope of health service. So this goes a lot around task shifting. So in public health, task shifting has been there for many, many years, but what I call as AI-powered task shifting can fundamentally transform the task shifting and address key challenges, such as the challenges in the intrinsic gap between non-expert who the task is shifted to versus the actual expert who would have been. Also in the training, because you need to keep on training, give personalized training. The third is the quality audits. How do you audit this task shifting? If people are doing cervical cancer screening, nurses are doing that, obstetric scans, but do you know at scale, at country level, this is being done at the quality that you want? And this is where also AI can really play a role. So AI-powered task shifting can be very powerful. And this is one of the terms I introduce, I keep on saying, I think, which now globally people are starting to pick up this term. Let's see examples. Cervical cancer, I think the previous speaker, she mentioned about cervical cancer. So we've worked on this. We've built models, did the first stage validation, which in partnership with the Dhalical Hospital and Kathmandu University, where we all know, so it's a preventable disease. If you find the precancerous stage, you can treat it very easily with thermocoagulation or cryotherapy, but still it's one of the largest killers, unfortunately. And pap smear, it has some challenges. VIA is typically known to be one of the most suitable for LMIC, but the challenge is it's highly subjective, and we don't have gynecologists everywhere to do this screening regularly. And we train nurses, so the government trains nurses, but then it's highly subjective, and that's where we built protocols, smartphone-based approach, which would assist the nurses to do this more objectively and more accurately. Other works, I'm quite excited about ultrasound because it's portable. Now these days this comes at a very low cost, and the cost will keep on decreasing in the next few years, where you have ultrasound in your pocket. You have smartphone or a tablet and a probe, and you can do so many things with high temporal resolution, no radiation, so we can really look into human body. And this is really powerful. I think we believe, the stethoscope used to be the symbol for doctors for many decades. Most likely ultrasound will be that in the next decades. But the challenge is limited field of view, and it's highly operator dependent. And this is where AI comes into play, where AI can assist the user. So nurses, doctors, and health professionals to do these kind of work, and which can bring AI-powered assisted or AI-assisted ultrasound can bring consistency. And because in ultrasound imaging, typically what you need is you need to find right views. You have to go around, probe around. If this is a probe, you go around the body to find right views. So that navigation is challenging. You need to build expertise. Then once you find right views, you need to interpret that, detecting certain conditions or measuring certain biometries. So these are the difficult challenges across different, so it could be fetal ultrasound, or it could be heart echocardiography, it can be hip displacement. There are many things where people use ultrasound, and most of the research has been around trying to help navigate, or once already the views are there, to detect that. But we are approaching this in a slightly different approach. There are a few groups around the world who are beginning to do this as well in recent years. Is how about just we take the videos, as many as possible, from everywhere, so then it becomes easier for anyone to take it without really bothering about what we see. Just take everything that's possible and let AI do the analysis. This was initially tried in teleradiology, but this wasn't successful because when we take all the videos possible, we don't get information in a very systematic way. It just comes, everything comes, and for a human reader, it's hard. So even for the expert radiologist, it's very hard to interpret that. But for AI, it's not that difficult. And this is where now people, so this is the example in the obstetric scan. So designing a protocol that's very easy to follow for anyone. So standard 6-sweep protocol. People are trying with different 6-sweep, 9-sweep, 8-sweep, but that's fine. But still, it's same consistent way to move the probe around. And you take the video. So we're doing multiple projects around this. One is where we lead an international study with teams in Africa, South Asia, and Nepal. We're collecting 2,000 data, blind sweep data, and then building AI models around that. We also work with companies like GE Healthcare, which is trying to build a new product, and we do the R&D on high quality assessment. So whether these videos are of enough quality that can be used for AI models downstream task or not. And our own local work with Patton hospitals and teaching hospital, Porapakar, Melanchi, few community hospitals, family welfare division, where we are collecting a large scale data, and we're doing field testing of these AI models around life-saving conditions, where nurses who are trained for rural obstetrics ultrasound scan, are they able to improve using the AI models we've developed. At times we need to build new things when we don't have any devices. Here the example is around CT scan. CT scan is very expensive in many towns. It's not available. So typically a rural trauma, rural surgery, it's quite important. But for surgeons, if we have the CT, they could see the whole 3D. It's much better. But when they don't have it, they still have to do it with X-ray, because they cannot, the patients cannot afford to go for travel, get expensive CT scans. And this is where we're building 3D models with AI based on the AP lateral views from X-rays. So this allows one to see it in 3D, and there were a number of work around this globally, and what we found were key problems, key challenges with the kind of AI work that was being done. And in this paper, we showed how the community should move forward to get closer to the clinical implementation of these kind of models. Similarly, now another example is around overburdened tertiary health care. So that's another kind of lack of experts. Where imaging, so radiology functions and around X-rays, we know that there are many underreported X-rays, especially in large hospitals, because they simply don't have time to go through X-rays around many different things. Here, one example around scoliosis, where you can measure these. So this was one of the first works we did when I came back in 2019. Around estimating the curve angle, which is important for the management of scoliosis in the adolescents. There are other groups. So this one example is from the other Binod's group within NAMI, where they work on better arterial segmentation and stenosis detection in the angiography, so that it's more accurate. Some other examples on lack of devices. We built a low-cost smartphone-sized microscope. So this is, I think, again, the previous speaker mentioned about diarrhea and these diseases. So we've done work and built models around your smartphones could be converted into your smartphones can be converted into microscope, and especially in the disaster areas, where if we want to test vegetable, water sources for certain parasites, and in this case, we were doing Cryptosporidium and Giardia. So on the top is the traditional biteful microscope. On the bottom is the smartphone microscope that was built, which is already validated, which is published, and then we built AI model to detect these things. So it goes through all the building, and then we worked on this with 3 provinces. So here's just the pipeline. I'll go very quickly on this because there's less time, but this, again, the bottom one is the smartphone microscope, and there are the results on how we the detection quality. It was slightly less, and then we are collecting much larger data and building new model, which means building the app, going to different places, collect all those data from different samples. So this is the summary, where we're collecting 200,000 images from vegetable, water, and stool samples across with different clinical partners in different provinces. Very briefly on resource constraints and other kind of work, because it's too little time to show all the work, so I'll just give some examples. So when there's data scarcity, we work on how to build better AI models with very less data. So a number of publications around those. When there is low compute, how do you do when you don't have these expensive GPUs, expensive computing power? number of work on this where we really push the frontiers of AI and give this knowledge to the global world. Neglected disease, there's another team, Raunak's team, leading where we're trying to build models to predict the multi-drug resistance from TB, and also trying to understand the mutation mechanisms. And then there's another work in vaccine development going on around this. Chatbots, we were evaluating at large scale in sexual reproductive maternal health when people use in Nepali language these things. And again, so I'll briefly go, there's 9,000 users across different, what are the risks, what are the capacity, what we need to improve to really for people to use these kind of chatbots in a safe, reliable way. So those kind of stats. And in trustworthy healthcare, we work, so this is a large scale collaborative with more than 100 scientists from around the world, where we have laid down the principles on how do you build trustworthy healthcare AI, and what are the principles. So here we saw these six principles, checklists, very easy guidelines that was published in BMJ, where I was also involved among many scientists from around the world. We work on other theoretical aspects, where how does the image and the language interact? So how do doctors work with the AI models in a more friendly way, and doing detailed analysis around that. Previous speakers spoke about explainability. So there's work on explainability, large scale work on federated learning. This is one of the amazing work, again, with other team at NAMI. This is globally picked up right now on how do you build this federated learning. So with this data privacy, where hospitals have their own data, everyone has their data, but how do you build AI models leveraging those data without getting the data in a central, without moving the data around. So again, these frameworks. So that's most of the work we've done, just to show that excellence is possible even from Nepal. And sometimes we hear there is almost nothing happening in Nepal. That's not true. We are actually doing a lot of work, and it has global recognition. I hope it will get more national recognition as well. Thank you.
Thank you, Dr. Vises. नामी इन्स्टिट्युटले नामी नै काम गराएर रहेछ, अहिले हामी डिस्कसन गर्छौँ. धन्यवाद.
Now I would like to invite Mr. Suraj Prakash Aryal to present on the digital health in Nepal, navigating the broad landscape to our nationwide coverage. Mr. Suraj Aryal is IT Director in Ministry of Health and Population, my colleague. So he's a member of the Working Council, ASEAN eHealth Information Network. Over to you, sir.
Respected Chair and everyone, good evening. So I am Suraj Prakash Aryal, IT Director from the Ministry of Health and Population. So my previous speakers, they talked a lot about the possibilities of AI in Nepal healthcare systems, and the use of AI in healthcare in India, and that possibility in Nepal as well. So rather than that, first of all, I would say that to assess our current scenario, we, as already said, one resource constraint that we are facing in Nepal in the field of excelling in AI, it is the data. The source of data, it is actually very important, and that is not only data, but a clean data and integrated data. So that is something missing, because we have a lot of fragmented systems across Nepal and they are not connected. So this is something in which the ministry is working upon. So I'm going to show a glimpse of what we are trying to do and what we are trying to achieve over the next few years, so that in Nepal, also in the field of healthcare systems, we can build good solutions, good applications that are very well supported with the AI data, and that could help our healthcare professionals to make the decisions in very effective manners. Ten minutes is quite a lot less time, but still. So when we talk about digital health, so now it's no longer a luxury, it's no longer, but it's a necessity. So now to make the scenario of the health landscape in Nepal a more usable one, so we need to excel very much in the field of digital health. And even the current government, it has also emphasized a lot of efforts in the field of digital health. Thank you. So now in case of Nepal, so we had National E-Health Strategy, and it was planned for 5 years, but the goals that it envisioned, they are still not achieved, and we're still working on that. And We had a Digital Nepal Framework 1.0 in 2019, and recently we have Digital Nepal Framework 2.0 that also emphasizes health as a very important sector that needs to be addressed upon. And then we had an integrated EMR operation and management directive in 2081, 2025. So that is also something that tries to standardize the EMR across the Nepal. And the main goal was to standardize the EMR system, standardize the data that we collected and collect it into a national health portal. So that is what we tried. And as of current scenario, we have a lot of smartphone penetration, and we have a government service integration portal, Nagrik apps, and we have a DHIS2 system and open source system working in the HMI section of the Department of Health Services. So based on these resources, now this is the base from where we are going to take off. So what is the? I think I skipped one. Okay. Ita. यो चाहिँ सेन्सर चाहिँ कता छ यता okay anyway so as of now we have a lot of disconnected systems यो ब्याक जाने चाहिँ गरिदिनु ए ओके So as of now, we have a lot of disconnected systems, and the patient's data that's scattered across the country, and we have no single integrated record of one single patient. So based on that, we are trying to build a national integrated health portal solution. So that combines all the EMRs in some kind of standards on the basis of some standards that we will be defining, and it will combine all the existing health information systems and the use of telemedicine solutions and everything into one single portal. And for that, and to cope up with that, we have to deal with these topographic structures and unstable power grids and internet supplies and fragmented donor fundings also, because the health sector in Nepal, I found out that it is majorly driven by a lot of foreign donations and fundings. And also the one thing lacking is the IT literacy workforce in the sector of health. So there's a mix, there's a balance, there's a lack of health force in the health focus who are literate in IT, and the IT workforce who are literate in health. So that mix is missing, and as of now, there are a lot of educational programs like in KU and even in the TU, they are trying to establish. So that thing is missing. So for that, we are trying to bridge the solutions. And when looking at the global examples, we can see the Estonia, they used X-roads, and their principle was to use one data at only once, to capture one data only once. And that is one thing that we could use for our data sovereignty. In India, the AVA and Universal Health ID, so they created, and the principle was to make a scalable digital ID that could be used across the health systems. And in European Unions, they did some data exchange protocols, and it had a shared data space across the EU nations, so that using these concepts, we could use the data exchange between the SAC interoperability. So for Nepal, we can leverage the existing DPIs like National ID and other systems to grow and make a unified national health. So this paradigm shift is necessary, because currently the hospitals, clinics, everything, they are working on their own kind of systems. So I think I'll show you the next slide. So this is something that we are working on. This is the major target of our ministry right now. So the main thing is the unique health ID that is missing in case of Nepal. So there are a lot of patients whose data is scattered across multiple EMRs and multiple healthcare systems. And there are a lot of programs that are trying to capture this data in a unified manner. And all are facing a single problem, that they are not getting real data. They are not getting accurate data. They are not getting accurate numbers. So for this, we are trying to implement a unique health ID. So that is something that will not replace the national ID, but that will use the national ID in the sector of health, so that every citizens who are trying to gain the health services across multiple facilities, either they be private or either be government facilities, they get a unique health ID, and whatever emergency systems or whatever healthcare systems across they come up with, they will the services they get will be identified with a single ID. So based on that ID, and there will be an exchange layer, data exchange layer. That will be an interoperability engine or an interoperable layer on which the data that is captured across the EMR systems can travel in a smooth manner and upon defined standards. And for this, we have health facility registries. We already have health facility registries, but it is not properly implemented, or it has not a full range of data, and there are strategies working on. We are working on the strategies to capture all the health facility registries and the workforce registries as well, because there are a lot of healthcare professionals who are working in diverse sectors. So the list of the health workforce registries that we have, we are trying to combine them into a single system, and which will be also a base for the applications that will be developed upon the systems, such as these AI systems or any other systems like telemedicine portals or the immunization dashboard or public health dashboard or any personal health record systems, the individual personal health record systems. All these will be built on top of these lower layers, so that whatever the data, all the systems, they can be accurate and they can be shared across the multiple applications. So we all know, I think everyone who are working in the sector of digital health, they know these standards, HL75 and SNOMED clinical terminology. So these are, this is the layer that defines the standards, that defines how data will be transferred from one system to another system in the layer. So these standards we are currently implementing using the standard interoperability lab in the Ministry of Health and Population. So we are using this standard. And then because of this, one patient data in one hospital, it can be easily transferred to another while referring or while doing analysis, so that when a patient goes to one doctor, then the doctor can easily use that patient's ID number and then sees all the details across all the facilities where he has visited into one single application. Of course, there will be issues like consent management and other things and privacy concerns. So they will also be addressed using the proper rules and regulations. And in Nepal, the Gandaki province they had done a significant amount of creating unique IDs of the people inside that area. And then the Information Insurance Board has used the OpenIMIS system also to manage the national health insurance. There are some experience upon which we can build this national health portal. And then the citizen engagement is also, I'll require some time. So, but to have all this, we should be backed up by legal resources. So right now, we do not have we are not much backed up by the legal things, but we will soon be overcoming them, because we have a governance blueprint, and that blueprint says that all the citizens, they will have a centralized data, their centralized identity, and there should be a Health Data Protection Act also that also we are working upon, so that it will actually guide us on how we could share the patient's data, because there will be a lot of sensitive data also, and health data itself is a very sensitive data. And the National Digital Health Policy is also something that we are working upon and will be bringing out soon, so that it will define how AIs and other technologies will be used upon the existing patient's records, and how the data can be shared, and how technologies can be used. So all these things will be defined in the National Digital Health Policy. And for this, financing is also a very important aspect that we should look upon, because there are a lot of issues in the government itself cannot sustain the burden of all the healthcare systems. Currently, if we then there are a lot of healthcare applications running individually and parallelly, and they all need to be brought up on one single portal. So that is something. So we will be using sector-wide approach. So we will be transitioning the fragmented short-term donor pilots into single pool systems, and we are also creating a national digital health blueprint also. So that will also guide us, that will also show us in which direction we are going to move on. So all these strategies, all these applications, they will be guided by a single blueprint systems. And public-private, of course, the initial speakers also talked about it. So public-private synergies, that is also very much required. And even the academia, like Dr. Bishesh, he said. So the ministry has to work with all these public, private, academia, everyone to bring together very useful solutions. And more than that, a domestic commitment is also very much repeated, so that every year, the government has to provide a fixed range of budget for fixed programs in the digital health sectors. So I will actually, these are some things that we need to do, but I think the strategic roadmap, the length of the years, I think it should be condensed, because now we are very proactive government. So I think hopefully this roadmap will be condensed into much lesser years, but still we have to roll out a unique health ID. We have to establish and verify the master facility registries and workforce registries, and then we will have to deploy the national health interoperable layer, and it is something we are already working upon, and then enact these laws that are required for this. And then we could scale out these to this system. We could pilot the systems to few hospitals, and then if that is very successful, then we could roll out it to all the local levels, at all ground levels. And there are even some other things that need to be done, because not all health facilities have even an EMR as of now. So that is something. So scaling needs to be done, and then it should be integrated in a national portal. And each individual citizens, they will be benefited with a unified citizen health portal, which could be a Meru Swasthya system. And then we could use this AI, use the advanced optimization using AIs and everything. But it doesn't mean that it should be started only then. It could start right now, but the accuracy would be better when we reach at that stage. So for that, we should have a human capital. So for that, the National AI Policy Commitment has also said that it will have more than 5,000 educated AI health professionals and digital health professionals, and we could change the curriculum, and we could incorporate the digital health and AI systems in the medical, even the medical digital health professionals, and we could empower the currently existing IT professionals in the field of healthcare systems, so that they will have a backup of public health, clinical health, a little knowledge of that could help them. And with this, I think we could build a healthier, equitable Nepal, and all of this mass that is present here, their contribution will be equally important to achieve this target. Thank you.
Thank you. Thank you. एकदमै राम्रो कुरा हुँदै रहेछ, आशा गरौँ चाँडै नै हुन्छ। अब च्यालेन्ज त धेरै छ, तपाईले धेरै भन्नुभयो, मल्टी-बिलियन प्रोजेक्ट्स देखाउनु भएको छ। लेट्स हियर फ्रम अदर्स।
Now we would like to invite Dr. Vishnu Prasad Marasane. He will talk about rational application of artificial intelligence and AI-driven tools. Dr. Vishnu Prasad Marasane is a Senior Research Associate at NHRC. He applies AI-driven and in silico approach to identify and optimize novel therapeutic candidates. He served as a head of Department of Biotechnology and leading multidisciplinary research team. Over to you, Vishnu sir.
Thank you, respected chairs. Namaskar sabaijanai. I would like to speak in Nepali. I requested Dr. Shruti Patil. She said she also understands little bit Nepali. अब यो मैले अलिकति टेक्निकल भन्दा पनि इन जनरल टर्ममै मैले कुरा गर्छु। अब यसमा रेशनल एप्लिकेसन अफ आर्टिफिशियल इन्टेलिजेन्स, अब हामीले एआई युज गरिरहेको छौँ, धेरैलाई अहिले जिज्ञासा पनि छ एआई भनेको के भन्ने कुरा प्रायले युज पनि गरिसकेका छौँ। तर अब हामीले रिसर्चमा, खास गरी रिसर्चमा कसरी युज गर्ने, अथवा रिसर्चमा युज गर्दाखेरि कति कुरा लिमिटेसन छ, कति कुरा छैन भन्ने कुराहरू पनि अलिकति म यहाँ थोरै हाइलाइट गर्न चाहेँ। अब एआईले गर्दाखेरि हाम्रो रिसर्च अहिले प्रपोजल राइटिङदेखि लिएर पेपर राइटिङसम्म डिसिजन मेकिङसँग धेरै नै सजिलो गराइदिएको छ। तर त्यो सँगसँगै केही बाधा अडचन व्यवधानहरू पनि त्यो देखिएको छ। त्यसमा अब हामीले युज गर्ने भनेको, अब वाइडली युज भनेको च्याट जिपिटी हामीले डेली लाइफमादेखि लिएर रिसर्चमा पनि हामीले युज गरिरहेका छौँ। कुनै डाटा खोज्नु पऱ्यो, कुनै लिटरेचरहरू खोज्नु पऱ्यो, कुनै त्यसको अरू अथेन्टिसिटीहरू खोज्नु पऱ्यो भने पनि हामीले युज गरिरहेका छौँ। त्यस्तै लिटरेचर एआई पनि छ, साइटेसनको लागिहरू पनि छ। त्यसमै अब मेसिन लर्निङ मोडलहरू पनि युज गरिरहेछौँ होइन। त्यस्तै गरी अब यहाँ मैले थोरै मात्रै यहाँ लिस्टेड गरेँ, जस्तै पर्प्लेक्सिटी अहिले वाइडली युज गरेको हाम्रो एकाडेमिक सेक्टरमा एकदमै युज भएको पर्प्लेक्सिटी छ। त्यस्तै क्लाउडी डाटा एनालाइसिसको लागि इत्यादि, जस्तै गामा एपहरू अब कहिलेकाहीँ पावर पोइन्ट प्रेजेन्टेसन गर्नको लागि पनि, पिक्चर ड्र गर्नको लागि पनि धेरै अब जस्तै अब नोटबुक एलएलएम अब पाइथन स्क्रिप्टिङदेखि लिएर अरूहरूको लागि पनि युज भइरहेको छ, हाम्रो डेली लाइफमा युज भइरहेको छ। अब यो गर्दा गर्दै पनि अब कतिपय जर्नलहरूले रिफ्रेन अवे फ्रम द एआई युजिङ भनिरहेको हुन्छ। कतिपय अब हाम्रो थेसिसकै एकाडेमिक सेक्टरमा हेर्ने हो भने पनि विद्यार्थीहरूले एआई युज गर्यो भने तैँले एआई युज गरेको, च्याट जिपिटी युज गरेको, च्याट जिपिटी पनि कहिलेकाहीँ युज गर्छ तर प्रोपर तरिकाले युज गरेको छैन, हुबहु कपी पेस्ट गरेको देखिन्छ होइन। त्यसलाई चाहिँ कसरी फेरि क्ल्यारिफिकेसन गर्ने भन्ने कुराहरू त अहिले गाइडलाइन चाहिँ छैन होइन। अहिले मैले अब हाइलाइट गर्न लागेको एउटा चाहिँ गाइडलाइनहरूको पनि एउटा चाहिँ बनाउनु पर्छ भन्ने पोइन्ट अफ भ्यूबाट पनि भयो। त्यस्तै गरी अब जर्नल सेक्सनहरूले पनि अब नाउडेज कति छ भने प्रपोजल पनि एआईबाटै बनाउने, अनि त्यसपछि रिभ्युअरका जान्छ, रिभ्युअरले पनि त्यो एआईलाई नै फेरि रिभ्युअर गर्न जाने होइन। मान्छे त त्यहाँ कोही युजै छैन, यता पनि एआई युज छ, उता पनि एआई नै युज छ, तर त्यसको प्रोपर युज चाहिँ कसरी गर्ने, त्यसको गाइडलाइनहरू के छ भन्ने कुराहरूमा हामीले कति समय युज गर्न मिल्ने, कति समय युज गर्न नमिल्ने, कुन कुरालाई युज गर्न मिल्ने, कुन कुरालाई युज गर्न नमिल्ने भन्ने कुराहरू अब यहाँ यसको केही गाइडलाइन बनाउन जरुरी देखिन्छ। त्यस्तै गरी अब यो थोरै मैले अब यसमा मैले किन जोड्न खोजेँ भने हामीले एआई नै युज गरेर जस्तै अब हामीले एउटा ड्रग डिस्कभरीमा एआई टुल युज गरेर हामीले न्यू प्युटेटिभ मोलिक्युलको एन्टी क्यान्सर ड्रगहरू पनि गरेको छौँ। त्यसको लागि हामीले के गर्यौँ भन्दाखेरि डाटा सेट युज गर्यौँ, एन्टी क्यान्सरमा युज हुने प्लस पब्लिकेसन जुन चाहिँ अब एफडीए एप्रुभ भएको पनि हुनसक्छ, नभएको पनि हुनसक्छ, टक्सिक भएर रिजेक्ट भएको पनि हुनसक्छ, अथवा माउस मोडेलमा फेलर भएको पनि हुनसक्छ, क्लिनिकल ट्रायलमा फेलर भएको पनि हुनसक्छ। त्यो सबैको हामीले लिस्टिङ गऱ्यौँ। 813वटा एक्टिभ कम्पाउन्ड रहेछ जुन चाहिँ एन्टी क्यान्सरमा प्युटेटिभ मोलिक्युलहरू रहेछ। अनि त्यस्तै गरी रिसर्च गरेर एन्टी क्यान्सरमा छैन भने डिक्लेयर गरेको, पब्लिस आर्टिकलबाटै छैन भनेर डिक्लेयर गरेको त्यो 710वटा इनेक्टिभ मोलिक्युलहरू पनि हामीले लिग्यौँ। त्यो मोलिक्युल ती सबैलाई हामीले लिइसकेपछि अब हामीले चाहिँ एउटा मोडल फिट गऱ्यौँ होइन। एआईले अब एआईको अब यहाँ मैले धेरै टेक्निकल यहाँ गरेको छैन, त्यसमा अब हामीले रेन्डम फरेस्टदेखि लिएर एक्सजी बुस्टदेखि लिएर न्युरल मोडलदेखि लिएर होइन, त्यसपछि लार्ज ल्याङ्ग्वेज मोडलहरू सबै 6वटा हामीले मोडल फिट गऱ्यौँ। त्यसमध्ये जुन चाहिँ बेस्ट मोडल आएको छ त्यही मोडललाई फेरि हामीले 1 करोड यी मोलिक्युल डाटाबेसबाट 1 करोड मोलिक्युलहरू लेख्यौँ। प्लस हामीले हाम्रै आफ्नो नेपालकै मेडिसिन प्लान्टहरू जुन चाहिँ आयुर्वेद अथवा ट्रेडिसनल मेडिसिनमा क्यान्सर अथवा अर्बुद रोग अथवा अरू सिमिलर टाइपको युज भनेर चाहिँ मेन्सन गरेको छ, ती प्लान्टहरूबाट पनि हामीले मोलिक्युलहरू लिटरेचरबाटै खोजेर झन्डै हामीले 500वटा जति डाटाबेस बनाएको छौँ ती प्लान्टहरूबाट। त्यसलाई पनि हामीले राखेर अनि हामीले सर्च गरेर गर्दाखेरि अनि टप 10 मोलिक्युललाई फेरि अब हामीले फेरि इनसिलिको र भर्चुअल स्क्रिनिङदेखि लिएर हामीले चाहिँ डाइनामिक्स पनि गरेर हामीले यो मोलिक्युलहरू पब्लिस गऱ्यौँ र +1 मा पब्लिस पनि भएको छ। सोफार आई नो जहाँसम्म लाग्छ यो हाम्रो नेपालमा ड्रग डिस्कभरीमा पहिलो आर्टिकल नै हुनसक्छ। अब हाम्रो नामीले पनि अरू फिल्डमा पनि गर्नुभएको छ, एआईमा पहिलो आर्टिकलहरू छ, ड्रग डिस्कभरी सायद यो हुनसक्छ, अरू पनि छ थुप्रै, मैले यहाँ एउटा मात्रै देखाएँ। अब यो मैले किन अब यो फेरि ब्याक टु हामी यो किन देखाएँ भन्दाखेरि अब हामीले यसमा यो एआई गर्नको लागि हामीलाई सबभन्दा पहिला चाहिँ अब अगाडिको प्रवक्ताहरूले पनि भन्नुभयो कि डाटा चाहिन्छ। एआईलाई जहिले पनि चाहिने भनेकै डाटा हो, डाटा मात्रै होइन करेक्ट डाटा हो है। डाटा पनि चाहिन्छ तर करेक्ट पनि चाहिन्छ। अब साइन्स र अरू बेलामा त करेक्ट डाटा भए पुग्यो, तर साइन्स र रिसर्चको लागि अथेन्टिकेसन पनि चाहियो। त्यो करेक्ट डाटाको सोर्स के, इभिडेन्स के, त्यो पनि चाहियो हामीलाई होइन। त्यो भएपछि बल्ल हामीले एआई बल्ल युज गर्न सक्छौँ। एआईको पहिलो लिमिटेसन, पहिलो ब्यारियर नै भनेको हामीसँग अथेन्टिकेटेड डाटा, अनि त्यो पनि लार्ज सेट अफ डाटा जुन अघि मैले देखाएँ 813 जुन 710वटा जुन मोलिक्युलहरू, त्यस्तै डाटाबेसहरू हामीलाई कम्तीमा पनि सेभरल डाटा सेटहरू र धेरै डाटा सेटहरू चाहिन्छ। जति थोरै डाटा सेट हो त्यति एक्युरेसी आउँदैन, एआईले काम गर्न सक्दैन है। हामीले कहिलेकाहीँ थोरै डाटामा पनि गर्छौँ, जबरजस्ती गर्छौँ, तर त्यसको एक्युरेसी र त्यसको रिजल्ट चाहिँ एक्युरेट हुँदैन। त्यस कारणले हामीले डाटा सेट चाहिन्छ। सबभन्दा पहिलो हामीले चाहिने भनेकै डाटा सेट हो है। अब हामीसँग नेपालमा त्यो डाटा सेट छैन। हाम्रो नेपालको आफ्नो वन डाटामा धेरै जसो कन्टेक्सहरूमा त्यो डाटा सेट छैन। त्यस कारणले गर्दाखेरि अब हाम्रो नेपालकै आफ्नै कन्टेक्सहरूमा अझ खास गरी हेल्थ रिसर्चहरूमा एआई टुल युज गर्न अहिले गाह्रो छ। त्यस्तै अब करेन्ट ग्यापहरू, अब ग्यापमा के छ, अब के ग्याप भन्दै एआई त हामीले युज गर्छौँ जानी नजानी अथवा डेली लाइफमा युज गर्छौँ, तर रिसर्चमा पोइन्ट अफ भ्यूबाट ट्रु तरिकाले एक्युरेट तरिकाले हामीले एआई रिसर्च गरेकै छैनौँ। त्यस कारण लिमिटेड नम्बर अफ रिसर्च ट्रेन्ड इन एआई। अब एआईमै फोकस भएर यहाँ गरेको जहाँसम्म लाग्छ धेरै कम छौँ। त्यस्तै गरी अब सर्टेज अफ इन्टरडिसिप्लिनरी टिम हुनै पर्यो। अब एआई मात्रै जानेर कम्प्युटर र मोडलिङ मात्रै जानेर पनि भएन, त्यसमा बायोमेडिकलको पनि जान्नु पऱ्यो, अनि क्लिनिकलको डाटाहरू पनि हुनु पऱ्यो, सबै इन्टरडिसिप्लिनरी रिसर्चहरू हुनु पऱ्यो। अनि त्यस्तै गरी इन्सफिसियन्ट कम्प्युटर इन्फ्रास्ट्रक्चर, अगाडि नामीको सरले पनि भन्नुभयो। अब हामीसँग हाई पर्फर्मेन्स कम्प्युटरहरू अहिले भर्खरै बल्ल अब ट्युमा एउटा मात्रै थियो, केयुमा पनि एउटा मात्रै थियो, अब हामीसँग एउटा थियो, त्यसपछि अहिले एम्बसले एउटा निकाल्दैछ, अहिले भर्खरै बल्ल सेटअप हुँदैछ, तर पनि अझै त्यो सफिसियन्ट छैन। त्यस्तै गरी अर्को चाहिँ स्ट्रक्चर करिकुला। अब एआई इथिक्सको कुराहरू आयो। अब एआईलाई कसरी युज गर्ने, कुन तरिकाले युज गर्ने, एआईको इथिक्सहरूको पनि त्यो छैन। त्यो ग्यापहरू अब एनएचआरसी मे लिड, एनएचआरसीले यो ग्यापहरूलाई फुलफिल गर्न सक्छ। जस्तै अब एनएचआरसीमा हाम्रो एकदम स्ट्रङ क्यापेसिटी बिल्डिङ सेक्सन छ, अलरेडी डाटा एनालाइसिस, अलरेडी प्रपोजल राइटिङदेखि लिएर अलरेडी धेरै कुराहरूमा मोडलिङहरूमा, डिजिज मोडलिङहरूमा एनएचआरसीको क्यापेसिटी बिल्डिङ सेक्सनले देशव्यापी रूपमा ट्रेनिङ दिइरहेको छ। लार्ज नम्बर अफ हेल्थ प्रोफेसनलहरू ट्रेन हुनुभएको पनि छ। त्यस्तै गरी अब नेक्स्ट फिल्डमा चाहिँ हामीले एआई बेसको ट्रेनिङहरू पनि दिन सक्छ। यो एनएचआरसीको क्यापेसिटी आफैमा छ। त्यस्तै गरी कोलाबोरेसन, एनएचआरसीले अलरेडी सेभरल इन्स्टिट्युटहरूसँग जस्तै हस्पिटलहरूसँग पनि कोलाबोरेसन गरिरहेको छ, प्रोभिन्सियल लेभलमा पनि कोलाबोरेसन गरिरहेको छ। एनएचआरसी आफैले पनि लिड रिसर्चहरू गरिरहेको छ, कोलाबोरेसन। त्यहाँबाट धेरै डाटाहरू जेनेरेसन हुन्छ होइन, अथेन्टिकेटेड डाटा। त्यो पनि जस्तै जिआइटिएसको अघि भर्खरै कुरा भयो, त्यसको डाटाबेस अनि स्टेप सर्वेहरूको डाटाबेस, जुन डब्लुएचओमा भएको डाटाबेसहरू त्यो एनएचआरसीबाटै ओरिजिन भएको डाटाहरू हुन्। तर दुर्भाग्य के छ भने त्यो डाटा डब्लुएचओमा सँग हामी एनएचआरसीले लिनु पऱ्यो, फेरि डब्लुएचओसँग माग्नुपर्ने अवस्था छ होइन। अब यसलाई चाहिँ अब हाम्रो कार्यकारी प्रमुख पनि यही हुन्छ, हिजो मैले अनुमति लिएको थिएँ। अब यस फिल्डमा अब हामी अगाडि बढ्दैछौँ र एनएचआरसी गर्न सक्छ, यो क्यापेसिटी चाहिँ छ होइन। त्यस्तै गरी अब इन्फ्रास्ट्रक्चर डेभलपमेन्ट, रिसर्च डाटा रिपोजिटरी, अब त्यसको अब डाटा रिपोजिटरी एनएचआरसीले आफैले गरेको अथेन्टिकेटेड डाटा पनि हुन्छ, कोलाबोरेटिभ रिसर्च। जस्तै युनिभर्सिटीहरूसँग भएको पनि डाटाहरू पनि हुनसक्छ, मन्त्रालयमा भएको डाटाहरू पनि एनएचआरसीले रिपोजिटरीमा राख्न सक्छ, या रिपोजिटरीको कोलाबोरेसनमा राख्न सक्छ, एपिआई कीहरू लिन सक्छ। त्यस्तै गरी अब इथिक्स, अब इथिकल गाइडलाइनहरू अलरेडी राम्रो इथिकल गाइडलाइनहरू, हेल्थ रिसर्च गाइडलाइन, यहाँ हरि सर पनि यही हुनुहुन्छ, गाइडलाइनहरू एनएचआरसी बनेकै छ। त्यो इथिकल गाइडलाइनको बेसिसमा इआरबीको अथवा आइआरसीको रिसर्चहरू ग्रान्ट एप्रुभल दिने कामहरू भएको छ। त्यस्तै गरी अब एनएचआरसीले एआईको हाउ टु युज एआई होइन, वेयर टु युज एआई, कहाँ प्रयोग गर्ने, कसरी प्रयोग गर्ने, कुन कुराहरूलाई चाहिँ हामीले एआईबाट कपी पेस्ट गर्न सक्छौँ, कुन कुरालाई हामीले चाहिँ मोडिफाई गर्न सक्छौँ। जस्तै कहिलेकाहीँ एआईले चाहिँ एनोनिमस डाटा दिन्छ कि दिँदैन, त्यहाँ चाहिँ के रिभिल हुन्छ कि हुन्न, त्यो रिभिल गर्ने कि नगर्ने भन्ने कुराहरू सबै गाइडलाइनहरू एनएचआरसीले गर्न सक्छ, बनाउन सक्छ भन्ने पोइन्ट अफ भ्यूबाट मैले यहाँ प्रेजेन्टेसन गरेँ। थ्याङ्क यू भेरी मच। र अर्को मैले टिम वर्क इज द अलवेज बेस्ट वर्क, किनभने जस्तै कोलाबोरेटिभ वर्क, यो जति पनि हाम्रो एआईको कामहरू गरेको त्यहाँ लार्ज नम्बर अफ टिमले नै गरिरहेको थियो, त्यस कारणले सक्सेस पनि भयो। थ्याङ्क यू भेरी मच।
थ्याङ्क यू डाक्टर विष्णु। यो यसो हेर्दाखेरि त एनएचआरसीले एआईमा धेरै काम गर्छ जस्तो लागेको छ। आउने दिनमा अब अरूको पनि प्रश्न लिउँला। अब नेक्स्ट प्रेजेन्टेसनमा जाउँ।
Now we would like to invite Professor Dr. Robert Thapa. She will talk about assessment of accuracy, feasibility, acceptability, and cost implication of enhancing access to the refractive error service through technology and task reallocation in Lalitpur in Dhading district, Nepal. Professor Robert Thapa is a professor of ophthalmology at NAMS and consultant of the vitreoretinal surgeon at Tilganga Institute of Ophthalmology. She holds a PhD from Birje University. Actually, I am also graduate from Birje University at Medical Center Amsterdam. Dr. Thapa has authored over 60 peer-reviewed publications and served as a reviewer and editor of the multiple scientific journals, including the Journal of Nepal Health Research Council. Over to you, Professor.
Thank you. Namaskar and good afternoon, respected chairs and distinguished participants. And I would like to thank the organizing committee for this opportunity. With the interest of time, I will go to my presentation. And these are the other co-investigators for this study. And we do not have any conflict of interest. And the outline of today's presentation will be like introduction, methodology, some objectives, results, and policy implications. Coming to the background, eye health is one of the very important component for sustainable development goal, and WHO has provision of this focused integrated people-centered eye care to ensure every people has the access to affordable quality and timely eye care service. And Nepal has adopted this policy since 2021, and refractive error is one of the very important morbidity and important cause of visual impairment globally and in Nepal. For this, WHO has initiated the SPECS 2030. It is regarding the access to eye care, personnel development, regarding the capacity enhancement, education, reducing cost, and surveillance. And regarding the current status of refractive error service, over 2.2 million people globally has vision loss. Out of these, the important fact is that 826 million have unaddressed near vision impairment. Likewise, 124 million have unaddressed distance vision impairment. In one of the recent meta-analysis, the prevalence of refractive error was 11%. The most important is the unaddressed distance refractive error in 7% and unaddressed near vision problem in 79%. Since last 1981, there has been rapid development in the eye care service, not only in the healthcare personnel, but infrastructure that has led to reduction of blindness from 0.84 in 1981 to 0.28 in 2021. The eye care service, the refractive error service has been provided mainly by the tertiary eye hospital, secondary eye hospital, and primary eye care centers. And primary eye care centers are mainly located in East District, and they are mainly focused on the education, awareness, vision assessment, refractive error correction, screening of the eye disease, and school eye health screening. However, the most important limitation is they are limited in the only in the there are limited service in the very rural areas, and only 40% of the people are still limited with the refractive error services. So the technology and task reallocation is very important component that has been given priority by the WHO, and it can help to reduce the cost and for accessibility of the care like in other diseases. So the refractive error can be corrected with this technology. So in this study, we have used that plain optica devices that is a very small, portable, handheld, and very accurate objective assessment of refractive error correction. And as a task reallocation, we have used the eye health personnel in the rural eye care center, and most important is the non-eye health personnel in the basic health service. So the main objective was to assess the accuracy, feasibility, acceptability, and cost implications of using these techniques and task reallocation for coverage of this refractive error service. So this study was approved by Nepal Health Research Council, and this is a cross-sectional study. Over 1,000 participants were enrolled as a sample size, and this was conducted in Lalitpur and Dhading district of Nepal. And these are 10 are the study sites, where 5 were the rural eye care center and 5 were the basic eye health service. We can see the health post and the basic hospitals in the rural part, like we know the Ruby Valley is very remote area in the Dhading district. All the consecutive cases were enrolled, and all patients included were the adult and having refractive error less than 6 diopter, but all the patients who are having cylindrical astigmatism of more than 1 were excluded. 3 research optometrists were enrolled for this study as a gold standard, and 2 allied health personnel from each basic health centers and ophthalmic assistant or optometrists who are working in the primary eye care center were enrolled in this study, and all received 2 days of training. And for the acceptability, feasibility, and cost, we have developed a standard questionnaire, and IC material were distributed in the community for the awareness, and accuracy was calculated by blinding the findings of eye health personnel and standard gold standard optometrists, and also the findings of the non-eye health personnel. And those in this, those patients having vision worse than 6/9 were included, and the 6/9 vision was taken as the normal. So these are some of the photographs used as a methodology. We provided 2 days of training in Tilganga Institute of Ophthalmology regarding how to use these plain optica devices and regarding the data collection. These are the pictures and real field pictures in the basic health units and primary eye care centers. And ComCare application were used for data collection, and SPSS 20 was used for the data analysis. The relevant statistical tests were used for the analysis. Coming to the result, we can see that almost 2/3 were females, and the average age of the patient was 53 years, with the majority having 51 to 60 years. The farmers were the main persons taking service, followed by the household workers, which we can imagine in the rural eye care centers and basic health service. Coming to the agreement accuracy, the agreement was assessed between the gold standard optometrist and IL personnel, and also the newly trained allied health personnel separately. We can see the very good agreement in this spherical equivalence, and also the visual acuity assessment. Regarding the cost, we have analyzed the overhead cost in terms of rent, electricity, Wi-Fi, water. We can see from the test that the range was from 5,000 to 15,000, and also in the health post area, basic health service, the cost was ranging from 3,600 to 5,000. And regarding the time, almost 68% of the patients were within 30 minutes of walk, while 87% had no need for any travel cost. And while if not using this technology, then almost half of the patient need more than 500 rupees as a travel, and even we can see the over 5,000. So while in other part, the optometrist salary is 65,000, and using this task and technology, the cost will be only 6,000. So we can see the very cost effectiveness. And regarding the feasibility, only 35% were using refractive error service, while 64% were not using this technique. And regarding the feasibility, almost all they were not using this technology because of the not availability of these devices and also lack of training. And regarding the feasibility, almost all agree that, almost over 90% agree that this technology is feasible in the rural eye care center and rural basic health service. Regarding the acceptability, almost 98% of the people were found acceptable with this technology. And regarding the scalability and sustainability, we can see that the use of plain optica, we can enhance the accessibility. This can be used by the allied health personnel. The acceptability and satisfaction was very high. So we can use this as a scalable approach in other similar areas. The implementation challenges are mainly, there is multiple responsibility for the allied health personnel in the remote areas and staff transfer. So regarding the policy relevance, the findings demonstrates the alignment with national and global priorities for strengthening primary eye care specs, that is, improve access for the refractive error service, build capacity of the local allied health personnel, increase awareness in the community, thereby increase health-seeking behavior, reduce cost, and strengthen the surveillance. So future direction is institutionalize the training to enhance the service access, to conduct operational research for its outcome, and integrating eye care in the basic health care. To conclude, it is feasible for allied health personnel to use auto-refraction for dispensing ready-made spectacles at the community level for people with simple refractive error to increase the access at rural areas. It can be a screening tool for detecting the complex refractive error for the referral to higher centers. These are my references. Thank you.
Thank you, Dr. Raba, for excellent presentation and keeping the time. Looks very interesting so that people in the rural areas get those services easily. We'll have more discussion after the session is over. So please have a seat and we'll continue with the next presenter.
Let me invite Mr. Ramchandra Thapa to speak on designing resilient assistive technology system through distributed manufacturing and local production case studies from Nepal. He is a researcher, consultant at GDI Hub program UCL. Over to you, sir.
So thank you. So myself, Ram, I did my master's in engineering for international development from University College London in 2022. And since then, I've been working with UK International Development funded AT2030, Assistive Technology 2030 program as a researcher and consultant. AT2030 program is led by GDI Hub, Global Disability Innovation Hub, and it's based inside University College London. So in this presentation, you wouldn't see much of a research structure, but rather a case study sort of flow. So at the end of the session, I'll try to build a case where I would be advocating that a shift from a mass manufacturing model to a localized, more distributed manufacturing model could empower our society or build more resilient towards our AT assistive technology provision models. So AT2030 program, it tests what works to improve access to assistive technology for all, because even today, more than 1 billion of the global population have some form of disability. And by 2050, more than 2.5 billion would have some form of disability. This means provisioning assistive devices which has potential to empower them through a centralized model may not work because each disability is very unique and they need personalized solutions. So could local production be the solution? So at AT2030, we work on 4 different themes. One is we work on data, evidence, and impact. We collect and capture data in different regions. We engage researchers, academicians, and innovators to deliver projects. We focus on innovation, so we work on pilots. We provide support to startups to develop more solutions. And we also do country implementation. So we have also got focus in Nepal. We have been working for more than 3 years in the sector of wheelchair and other assistive products. And by doing this, we empower, we capacitate the local ecosystem, and we build the systems. So let me quickly take you back to 2015. There was a big earthquake, which we all remember. It took lots of lives, left people with injury, lifelong injuries. And right after that, we had a terrible economic blockade, which we can't forget. That led to shortage of medical devices. Even critical items were difficult to source. So this means, you know, this left a lesson to me that catastrophe doesn't happen alone. You know, it comes in a series. There is a series of events, and that leaves you with a big pain. So how can we build a system which is more resilient to the shifts, to the change? There's a big advantage of mass and global manufacturing. It's produced at a source, in mass, at low cost. There's a good quality control mechanism to it, great product quality. But then, once it gets to user starts to use it for couple of months or maybe a year, and then he or she would require repair and maintenance services. That's when we begin to think locally. And if these repair and services are not available, the product would end at abandonment. So users would stop using it. This means the product life cycle is shortened. And with local approach, there is a shift. There is availability of material recovery. We could scavenge product, recollect parts that could be reutilized to build another product, could be recycled and fed into the production ecosystem, and everything just remains in the country. So we basically build the entire production ecosystem. So I did my master's thesis in wheelchair provisioning model, and I found out that in the countries like Nepal, we very much rely on charitable distribution model, where the product comes from other countries, a random product ends with the user. Mainly NGOs and informal sectors, even individuals, charitable persons are engaged in this delivery. And then when users do not have repair options, they again go back to these NGOs and charitable persons to request for another product. So what's happening is, instead of having a sustainable model for this product delivery, a same user is either repeatedly asking for the product, putting pressure on the provision system, or a user who doesn't have any access within the system is never receiving it. During COVID, we did a great pilot. We distributed more than 40,000 personal protective equipments, all by producing it locally. So we adopted the same distributed manufacturing models, where these face shields and goggles were made from more than 6 local makers, and that was possible. So in our wheelchair study, we found out that the assistive technology has a great impact on person. In fact, the two friends, we started their life together. One fell in a bike accident and never got a wheelchair for the another 5-6 years, and that left him quite behind in his career. So what an able friend achieved in 26 years old, it took the disabled friend more than 40 years of his age to achieve the same state. So assistive technology could really empower person with disability. So in most of the activity that I do, I implement 3D printing as a system to deliver products locally. So in this particular project, we made spare parts by utilizing 3D designs. We made it using standard filaments. We tested and then fixed wheelchairs. So we were able to identify more than 16 components of a wheelchair and fix these devices. So most of these components are non-load bearing parts, so it doesn't create a big impact on the structure of the wheelchair itself, but it does contribute in the extended life of this product. So all these different components were 3D printed. And in another pilot, we were implementing 3D digital technology to provide prosthetic devices to users. So UNICEF and us, we worked with local partners. We delivered more than 75 transtibial prosthetics by doing 3D printing. So in this image, this girl uses 3 devices. She has congenital limb difference, and she would require a cosmetic hand, a transtibial prosthetic, and a partial foot. She used to be carried by her mother to get from home to school, but after using these products, she is now able to do everything on her own. The process involves first scanning and then modifying it in 3D software then producing it using a 3D printer, using standard polypropylene filament, and then it involves further rehabilitation process where a user goes through fitting, further training, and then lots of repairs and follow-ups. So the entire process while using 3D printing was shortened from days to hours, because the other conventional way of delivering standard prosthetic is very long. And a user would require more than 3 or 4 prosthetics in a lifetime. That's what the research showed. So now what I'm trying to say is a shift from charitable distribution to a need-based local distributed manufacturing system could change the way that we have been delivering aids or the way that we have been delivering products. So the framework suggests that if we could have distributed networks of these local manufacturers or local clinicians working in an ecosystem model, then the things could be made locally, utilized locally, fixed locally, and then at the end of the life cycle, it could be recycled and feed it back into the production system. So the entire system would be more resilient and sustainable. So behind this is a great team of mine, clinicians, engineer, and a project manager who has a background in social development. So thank you.
Thank you. Thank you, Ramchandraji. Very interesting. We'll have more questions to his presentation. Looks quite interesting and maybe can support communities in need.
Now, let me invite Alicia Karki to deliver on co-designing a digital health tool for the intersectional stigma assessment and reductions in the multiple level and multiple dimension to improve HIV care in ART Center in Nepal. She is with the Master Degree in Public Health from IOM. Alicia Karki is a dedicated public health professional with over 5 years of experience in research, program implementation with a strong foundation in mixed method and participatory research. Over to you, Alicia.
Thank you, sir. I hope it's still afternoon or evening. Anyways, good afternoon, everyone. I'm Alicia Karki. I work as a researcher in Possible. And today I'll be sharing our work on co-designing a digital health tool called INCLUDE, that stands for Intersectional Stigma Assessment and Reduction at Multiple Levels and Multiple Dimensions. And our work mainly focuses on improving HIV care in antiretroviral therapy centers in Nepal. Before I move on to my other slides, I would like to thank all the co-authors, our senior authors who have contributed to this work. This is how I have outlined my presentation. Let me begin with the background here. People living with HIV, they go through several medical challenges throughout their lives. And beyond that, they face stigma and discrimination, which is equally adverse. And, equally adverse. And stigma means being excluded or treated differently because of a part of their identity. And for some people, they fear this discrimination, which we called anticipated stigma, and some have actually experienced this stigma, which we called enacted stigma, and some people think negative about themselves and blame themselves for the condition they have, and we call it internalized stigma. And all this stigma does not occur from just one direction. It occurs at multiple level and multiple dimension. Imagine a person, someone who is living with HIV, belongs to a marginalized group, and is also a gender minority. They face all the stigma at once, and which we called intersectional stigma. So when the stigma overlaps, it creates compounded barriers, and it ultimately impacts on the outcome of the person. So now that we know what intersectional stigma is, let's understand what are the current practices not enough to address the intersectional stigma? So if we see the recent data published by HIV Stigma Index, it shows that among the PLWH, that is person living with HIV, it's a quite long name, so I'll refer to PLWH throughout my slides here. So PLWH who stopped ART medication, they mentioned that 49% of them mentioned that stigma was the main reason behind the interruption. And if we see the current practices, the assessments are rarely multidimensional. Even if the stigma is identified, these are the responses are same for everyone, despite what the specific person is experiencing. And additionally, these stigma assessments are not integrated into the clinical routine care. And all these leaves the intersectional need unaddressed. And this impacts on the HIV outcomes. And more importantly, since the Nepal government is committed to eliminate HIV-related stigma and discrimination by 2030, it's really crucial that we address this intersectional stigma. For this, to support this goal, we aimed to develop a digital health tool called Include that assess intersectional stigma at multiple levels and dimensions targeted for people living with HIV and healthcare workers. So for this objective, we firstly developed a visual model, how the digital tool would look like. So it comprises of three major components. The first one is assessment, where it includes stigma-related experiences, and this leads to a clinical interface that shows the result based on the assessment, that is a dashboard, and then this leads to stigma reduction activities. For this visual model to be developed into an actual working tool, we used a human-centered design approach, which is based on 5-step design thinking process. Here, the first 3 initial steps have been already completed in our previous work, and this current study focuses on developing the prototype and then testing this into the real clinical setting based on those completed 3 initial steps. So this is grounded on a participatory co-design approach, which means we involved people who actually use the tool to co-design this digital health tool. For this, we formed a co-design committee of 15 members, and it was a long process, a 9-month process, which started from March until November, and we conducted 13 structured co-design sessions and a lot of asynchronous feedback from our content experts and domain experts. And throughout this co-design approach, we set the foundation of study, sharing experiences on intersectional stigma, and brainstorming how the tool would look like, followed by mock-up sessions and pre-pilot testing before finalizing the prototype. And this pre-pilot testing was conducted in Sucraras Tropical and Infectious Disease Hospital in Teku to test the functional and contextual reliability of the tool. So now I'll be showing what the actual tool we developed based on the visual representation. So I would just like to remind you the flow before I move on to the actual screens. So the first one is assessment that leads to dashboard, that is a clinical interface, and this leads to the recommendations under stigma reduction activities. So this is how the actual assessment form of the digital tool we developed looks like. The first one is component is assessment, which is to be filled by the people living with HIV. So it comprises of 3 major types of stigma, and the flow is simple here. It starts with a prompt, and it's followed by the stigma-related questions, followed by the driver of that specific question, and then by rating the selected dimension. So if you look at here, after the prompt, here you can see the questions that is based on the stigma experience of a person. Based on the response to this question, the participant selects the dimension of what is driving that particular experience, and then they rate the selected dimension from 1 to 5. So this is the dashboard, what the counselor sees after the patient, after the participant fills of the form, assessment form, and comes to the counselor room. The counselor shares it is not just limited to the counselor, so they share with the participant what stigma they are facing and what dimensions or what is driving that stigma, and what makes include different from the current approaches is the intersectional stigma calculation, where we have incorporated the stigma drivers into a validated mathematical calculation to calculate the intersectional stigma. So based on this, using a motivational interviewing technique, the counselor shares the score with the participant. So this way, based on the result that is displayed on the dashboard, we can see the stigma reduction activities displayed on the dashboard, and the counselor, they refer the specific resources that you can see the QR codes there based on the interest of the PLWH. So now I would like to conclude with key learnings and insights we had throughout the co-design process. First one being creating a safe and inclusive co-design space was really important. And yes, it needs a deliberate effort since we have people from different backgrounds and power dynamics. And ensuring everyone's voice is heard was equally important. For this, we encouraged open and non-targeted conversations. And of course, the emotional safety matters here. And we ensured that a dedicated clinical psychologist was present in each session throughout the co-design session. So lastly, visualizing the tool early was really helpful to understand what the tool looked like and also gaining meaningful feedback to refine the tool. So further, we're testing this tool in 4 ART sites of Nepal to evaluate how feasible and acceptable is it among the end users, that is the people living with HIV and healthcare workers. So the final takeaway would be co-designing a tool like Include, a digital health tool like Include, by involving the end users. For Include, it's people living with HIV and healthcare workers. It ensures that the tool is culturally appropriate and acceptable and genuinely meets the real needs of the people. And while Nepal is committed to eliminate HIV-related stigma and discrimination to end its epidemic by 2030, Include contributes by addressing the intersectional stigma. So lastly, I would like to acknowledge all our partners and collaborators, and yeah, thank you, that's me.
Thank you, Alisa. Very much on time. So we'll have more questions because if we give you more time, there will be stigma.
Yeah.
So let's have less stigma and have discussion at the end.
So next speaker is Ranjana Koyala, a research project manager at NAMI. I think second speaker from NAMI with a multidisciplinary background in nursing and public health. Her work focuses on advancing AI-driven health research with an emphasis on innovation, evidence generation, and real-world application in low-resource settings. So I would like to invite Ranjana Koirala. Over to you.
Respected citizens here, all the respected dignitaries present here, fellow presenter, and all the participants. Warm good evening. I'm Ranjana Koirala from NAMI, and it's my absolute pleasure to be the part of the conference and to present our ongoing research project entitled on AI-powered task shifting for high-quality fetal ultrasound service in community healthcare setting. And I would like to acknowledge our all the investigator and our study partner, Institute of Medicine, Parupakar Maternity and Women's Hospital, Family Welfare Division, and Solukhumbu Polytechnical Academy. This is the presentation overview. And starting with the introduction, as you all know that high maternal mortality persists in rural and low middle income countries like Nepal, and due to lack of early complication detection. And there are a barrier because of there are lack of infrastructure like ultrasound machine, ultrasound hardware, and trained experts like radiologists, and that prevents routine prenatal imaging. And to bridge this gap, the government of Nepal has employed task shifting approach, which delegates specific diagnostic tasks from high specialized doctors to health worker with shorter training, such as nurses or midwife, from under the program of Rural Obstetric Ultrasound Program. And there is a health system gap. Traditional task shifting often can fail due to higher operator objectivity, and it needs continuous monitoring and evaluation. And there is a good news. AI has potential to be used in task shifting for better USC interpretability. But AI method for fetal ultrasound has mostly focused on the DIME score and classification accuracy. And there was a need to evaluate AI impact on clinical decision making, especially in rural settings like Nepal. So this study proposed a solution, a diagnosis support tool that analyzes blind sweep obstetric ultrasound, that's called BSOU, for classification in downstream tracks such as placenta location, fetal presentation, to be deployed in low research setting. And the objectives of our study is to develop and evaluate an AI-powered task shifting to assist community health nurses to identify abnormalities, estimating anatomical markers, and with specific objectives of developing AI tool to identify anatomical marker like placenta previa, intra and extra uterine, single and multiple pregnancy, fetal viability, and so on. And also, also another objective is to perform field testing and pilot evaluation to assess the efficacy. Moving on to methodology, this is the cross-sectional research design, and for the AI model development, we have planned to collect 9,000 data from the multiple center from Institute of Medicine TUTS, from Paropakar hospitals and multiple community center under the collaboration with Family Welfare Division. And also we have planned to conduct field testing and pilot evaluation of the prototype. And so far, we have collected around 5,000 number of data from TUTS Hospital, Paropakar Maternity Hospitals, and Melamchi Hospital. And I'd like to give a brief on how we collect the data. First of all, after the eligibility and the consent form, patient's unique anonymized ID is created, and it is generated via our app. And after that, we collect the blind sweep obstetric ultrasound, and that is of 9 sweep, and that is of around 5 to 10 second video, which has 5 vertical line and 4 transverse line, and that is operator independent protocol that we have made, and that covers the complete visualization of anatomical marker of fetus and placenta. And after that, we also collect the associate scan, standard of care scan, that is conducted by radiologists when patient come to the regular visit. And that is also used to annotate data and to further refine our model. And also we collect the questionnaire that is also based on the standard of care findings. And this is our 9 blind sweep protocol, which has different anatomical trajectory. For example, sweep 1 from the top symphysis pubis to the top of the Gifford process to the pubic symphysis, and so on. And this is the sample that captured multiple sweep video following the predefined anatomical trajectory. And moving on to the results, about the label distribution, that is the descriptive data that has different category, that is an absolute placenta location, relative locations of placenta to cervix, cervix anatomy, ectopic and non-ectopic, and that is the graphical representation of those data. And on the level distribution, that we have also fetal presentations data, placenta previa and non-previa, presence of heartbeat, and single versus multiple pregnancies. And moving on to the, and also there are trimester distribution of data. Most of the cases are third trimester followed by second and first trimester. And talking about the model performance on fetal presentation, here in the table, you can see that 3 kinds of data. Model accuracy, that is based on the FN score, and it's sort of FAMLI, that is the data based on the external data set, which has the 73.3 model accuracy, and this study has the 75.5, and combining both data has the 75.5 and SOTA state of the art, who is the highest model accuracy, which is 95%, which is the pretty good model accuracy. And on the model performance on placenta location, in this table, family dataset has 88.6% model accuracy, whereas our study has the 84.9, and combining 95.5% model accuracy. So moving on to the product, what we have so far, we have the operational system. We have the platform that integrated with the PACS system that receive, store, and visualize data, especially in the DICOM format. And also we have mobile app which generates unique anonymized patient ID, which follows all the ethical components and which is completely anonymized. And we have 9-sweep protocol, and it takes a lot of time to design that protocol that covers, that visualize all the anatomical markers that requires for our study, which is Cineloop video. I already talked about that. And we have also dashboard that allows expert like radiologists to annotate the clip and visualize all the data day by day and week or month. So moving on to the conclusion, I would like to say that this is not just a research project, this is the project with vision where we want to decrease the maternal mortality and morbidity rate of pregnant women, especially in the resource concerned setting. And which aims to improve the diagnostic accuracy of obstetric ultrasound performed by community health nurses. And conclusion, it has very much potential that transform task shifting by scaling high quality fetal ultrasound to remote community center. And our moving forward, our next step is we will be collecting data. We have collected 5,000, and we are more to collect few thousands data by this August 2026, and we have planned to conduct the field testing among the 500 participants. Also, our model will be continuously iteratively refined to build and validate final model. And that is all about my presentation. Thank you so much, all of you, for listening.
Thank you, Ranjana ji, for keeping your time and very interesting presentation. Hopefully your model will be useful in rural Nepal, so women will be benefited. Thank you. We'll have more questions after the presentations are over. Please have a seat.
Okay, next speaker is Sandhya Nirola. Sandhya Nirola is a public health graduate from CDPH IUM and an early career researcher. Her research interests focus on digital health, non-communicable disease, and sexual and reproductive health and rights. So, Sandhya, so you are speaking on assessment of the ownership, frequency, and smart device usage, and the accessibility of the digital health data sharing among hypertensive patients in a tertiary hospital in Nepal. Over to you.
Thank you, Chair, for your introduction. Good evening, everyone. I am Sandhya Nirola. I recently completed my bachelor's in public health from Institute of Medicine. And today I'll be presenting on the topic assessment of ownership, frequency of smart device use, and the acceptability of digital health data sharing among hypertensive patients visiting a tertiary care hospital in Nepal. So we live in an era of rapid digital connectivity, where this digital connectivity has created a foundation for modern public health. The internet penetration rate worldwide is 73.2%, and there are 16.6 million internet users in Nepal. as of late 2025. Similarly, 85% of the households own smartphones in Nepal, and the wearable electronic market is predicted to grow massively in the upcoming years. So all of this creates an opportunity for us to transform how we deliver healthcare, especially when it comes to chronic conditions, which includes hypertension. In Nepal, more than 20% of the country's population above the age of 15 years suffer from hypertension. Despite the availability of effective treatment, challenges due to inconsistent monitoring and delays in intervention exist. So this is where digital health can come into play by enhancing medical adherence, remote blood pressure monitoring, real-time clinical feedback, support for lifestyle modifications such as improved physical activity and dietary behaviors. So you can see a picture here which shows an illustration of how this entire digital ecosystem might work. The increasing adoption of smart devices such as smartphones, wearable devices, smartwatches, has been massively increasing, which creates an opportunity for us to collect large volume of physiological activity data and behavioral data to be continuously collected in our naturalistic setting, actively and passively. So this enables us with the opportunity to connect patients with healthcare providers beyond their traditional healthcare settings. But the big question is, are the patients in Nepal ready and willing to be a part of this ecosystem or not? So in order to answer this question, we looked at the existing literature and found major key research gaps. There was lack of evidence on patient-level readiness and willingness for data health sharing acceptability. Lack of studies assessing the acceptability of sharing different types of health data, and there was no integrated assessment of smart devices ownership and usage patterns among hypertensive patients. So the objective of our research was to assess smart devices ownership, usage patterns, and acceptability of digital health data sharing among hypertensive patients attending a tertiary care hospital in Nepal. Moving on to the methodology section of our research, we conducted a cross-sectional hospital-based study at the OPD of Manmohan Cardiothoracic, Vascular and Transplant Center, Kathmandu, Nepal, from July to August 2025. We recruited 394 hypertensive patients using consecutive sampling. The inclusion criteria of our study included participants who were aged above 18 years and also were diagnosed with hypertension. In order to diagnose people with hypertension, we physically went there in the hospital of the OPD and physically measured the blood pressure. We used a validated automatic monitor, which is called as Omron HEM 7120 model, whose picture is attached in the slide here. We took average 3 readings, and the average reading was used. People whose systolic blood pressure was equals to or higher than 140 mm of Hg, or diastolic blood pressure equal to or higher 90 mm of Hg, or people who are taking antihypertensive medicines were included in our research. For the data collection, we used face-to-face interview. It took about 25 to 30 minutes each. It was carried out by trained undergraduate public health students, and the tool that we used was smartphone health assessment for digital engagement. For the statistical analysis, we used SPS version 27. We used independent sample t-test to compare the mean of health sharing willingness scores among different groups. And multivariate linear regression was used to estimate associations. Now, moving on towards the finding of our study, 92.6% of the hypertensive patient used smartphone, and which was very high in comparison to other communication technology that were currently being used. Similarly, smartphones the mean frequency of smartphone usage was very much in comparison to other communication technology again. Now, talking about the digital engagement the patients had, about 95% of the hypertensive patient had daily internet access, and 16.8% of the people were already tracking their workout and fitness routines, whereas 3.1% of the people were tracking their health parameters and 1.7% were tracking their sleep parameters. Whereas 91.9% of the people used smartphones as their primary device for accessing the internet. And in the last 6 months, 11.7% of the people were using a smartwatch. Similarly, more than half of the participants, 51.8%, had used internet to search for health-related information. Now, talking about the willingness to share health data according to data type. On the basis of data type, physiological data was the most amount of people were willing to share physiological data, which stood at 74.9%, which was followed by I can't see the number, but it was followed by sleep monitoring data, which is again around 70%. And talking about the willingness of participants to share the health data with different recipients, almost all, 99.5% of the people were willing to share their health data with healthcare providers, and 75% were willing to share the healthcare data with researchers. Whereas there was a major drop in willingness to share the health data when it came to informal recipients such as family and friends. Now, as I mentioned that the willingness of the people were very high, that we also need to acknowledge that there were concerns at the same time. The most prominent or dominant concern regarding the health data sharing was privacy concerns, which was followed by data misuse concerns. So, talking about the factors associated with willingness to use to share health data, higher education, higher income, higher household income, and English language proficiency and smartphone usage in the past 6 months was associated with higher willingness to share healthcare data. Whereas people who belong to large families had lower willingness to share health data. This could be drawn to reasons such as maybe health decisions in a large family are not taken in an autonomous manner, and a lot of family engagement is there, so which can make a participant, an individual, more concerned about the concerned and cautious about the health information that they're sharing with other people. So I also need to acknowledge the limitation of the study before drawing conclusions. So there might have been reporting bias, as our study was based on self-reported measures, and there's definitely limited generalizability because the study was conducted in a tertiary care hospital located in Nepal, in Kathmandu, so it might not fully represent the rural areas of our country. And we use consecutive sampling, so participants that were available on the study days may not fully represent the entire hypertensive patient population in the country. So to summarize the presentation and to summarize the key takeaways of what I spoke, I think there is very high digital readiness here because vast majority already owns a smartphone and they have daily internet access. Similarly, there was high willingness to share health data with healthcare providers and health researchers, but privacy concerns and fear of data misuse still persist, so we need to acknowledge that as well. And there was significant digital divide that we could see in our study. Lower income people, illiterate people, non-English speaking participants had significantly lower digital willingness to share the health data. So we call for inclusive interventions. It is very necessary for us to improve digital health literacy for patients with low literacy. And it is utmost for us to develop multilingual digital platforms, including in Nepali. And it is very important for us to ensure transparent data governance and strong privacy protections. With this, I've come to one end. So this is the last slide that shows a picture of me and says that my interest area lie at the intersection of non-communicable disease and digital health. We can get connected through my LinkedIn, my email, and my social media. At the end, I would like to acknowledge Apara Innovations for funding my bachelor's thesis. And I would also like to thank Manmohan Cardiothoracic Vascular and Transplant Center for coordinating with me for the entire data collection process and all the enumerators. And my deepest thank you to all my co-authors and my mentors for being a great support for this entire journey. Thank you.
Thank you, Sandhya ji. आजको सन्ध्या राम्रै भयो र हामी सन्ध्याजीसँग अरू क्वेसन एकछिनमा गरौँला। Let's go to next presenter.
I think we are almost at the end of this session. So the second last presenter is Dr. Srishti Singh, who is a medical doctor with MPS degree, and she is currently working as a project manager at Oxford University Clinical Research Unit in Nepal, and she will be delivering a talk on surveillance of the community-acquired pneumonia, potential for the wearable devices and remote monitoring system in Nepal. Over to you, Dr. Srishti.
Thank you, respected chairs. Good evening, everyone. I'm Dr. Srishti Singh, currently working at Ukru, Nepal. And today, the topic of my presentation is surveillance of community-acquired pneumonia, potential for wearable devices, and remote monitoring system in Nepal. So this is a descriptive analysis of a study which has been conducted in government tertiary hospital in Nepal. And the analysis of this study is still ongoing. So, sorry, I think the presenter took the pointer. So these are my co-authors. Community-acquired pneumonia is a major cause of severe infection and deaths across LMICs like Nepal. And in severe cases of community-acquired pneumonia, rigorous monitoring and early detection and prompt intervention is a key to save lives and also for effective patient care. But in countries like Nepal, in the LMIC settings, the healthcare system is often overburdened with patients and resources are limited. So it's a key challenge in effective patient care delivery. The objective of this analysis is to demonstrate the demographic profiles of inpatient severe pneumonia cases, their hospital trajectories, to demonstrate their data collection metrics and the risks for patient deterioration and mortality using scores like NewScore and SOFA score. And also to emphasize the feasibility and potential benefit of using wearable devices and continuous remote monitoring for critically ill patients. So as I mentioned, that it is a part of a prospective observational mixed method study, which has been conducted in a tertiary level hospital in Nepal. And in this study, we used low-cost wearable devices, which included a pulse oximeter and ECG recording patch. The difference of these devices, these wearable devices, than the conventional devices that we are already using in our healthcare setting is that they were more handy. They didn't have necessary wires, and also they were low cost and easy to use. So we assessed 100 patients who were enrolled between September 2025 until February 2026. So the data analysis was done on variables like age, sex, comorbidities, news and SOFA variables, duration of hospital stay, and events during hospital stay. And we also assessed the average hours of PPG and ECG data collected per day per patient, average days of data collected per patient, and average hours of data collected in the first 24 hours per patient. So during the first 24 hours, we were continuously monitoring the patient. After the first 24 hours of enrollment into the study, we monitored the patients using the ECG patches until discharge, but the PPG devices, the pulse oximetry was used only 2 hourly per day until discharge. So going on to the results, so in this analysis, the majority of the patients were aged 60 years and above, and a few proportion of the patients belonged to the age group of 30 to 59, and very few patients were less than 30 years. And there were a high majority of females in the study. And majority of the patients had at least one comorbidity or none. 43% of the patients, they had multiple comorbidities, which included hypertension, diabetes, renal, liver diseases, respiratory and cardiovascular diseases, and other various chronic illnesses. So at enrollment, more than 2/3 of the patients, they showed high risk of clinical deterioration using the NEWS score, based on the NEWS score. And on the basis of the SOFA score, we found that majority of the patients, they had lower mortality risk. And a few patients, they had moderate mortality risk. So during the hospital stay, about 36 patients, they stayed for up to 4 to 7 days. And over a third of patients, they stayed for more than 7 days. And only 30% of patients, they stayed less than 7 days in the hospital. So during the hospital stay, a majority of the patients, they received supplemental oxygen and also received more than one antimicrobial therapy. And few patients, they also received hemodialysis and vasopressors. So during the hospital stay, we were able to capture the pulse oximeter and ECG data of the patients. So on an average, we captured about 6 days of PPG data and 5 days of ECG data. And on an average, we captured about 4 days of PPG data per 4 hours of PPG data per day for each patient, and ECG data 19 hours per day for each patient. And in the first 24 hours of continuous monitoring, we were able to capture at least 20 hours of PPG data for each patient and 21 hours of ECG data per patient. So from the findings of this analysis, including the demographic findings and elongated hospital stay and the NEWS and SOFA scores that we conventionally use in the ICUs and emergency departments of the hospital, and also the treatment modalities that were used in those patients that we analyzed, I think it's fair enough to say that there is considerable risk of clinical deterioration among severe cases of pneumonia. And this necessitates intensive monitoring and prompt management to improve the patient outcome. But it's very unfortunate for a healthcare setting like ours, where the healthcare system is overburdened and the task force is already exhausted. So I would like to draw a conclusion from my analysis that using low-cost wearable devices and doing continuous remote monitoring on patients who are severe or critically ill would most definitely benefit them, as well as it is feasible to monitor them to enable task shifting, which has been coming up since the beginning of this session, and also it will help in efficient patient management and improving patient outcome in critically ill patients. Thank you for your attention.
Thank you, सृष्टिजी. तपाईँको सृष्टि राम्रो छ. हामी त्यसमा डिस्कसन गरौँला. अर्को लास्ट प्रेजेन्टेसन सुनौँ, त्यसपछि हामी सबै जसले प्रेजेन्ट गर्नुभएको थियो हामी अगाडि आउनलाई अनुरोध गर्छौँ. लास्ट प्रेजेन्टेसन पछि हामी इमिडिएटली विल गो अन क्वेसन एन्सर्स.
Okay, now the next speaker is Amsu Dakal. She is a researcher at Monmouth Memorial Institute of Health Science, and her work focuses on health system research and strengthening with a strong commitment to evidence-informed public health solutions. Amsu Dakal is speaking on implementation bottleneck in the evidence-informed decision-making in Nepal's federal health system and inter-level participatory policy analysis. Over to you, Amsu.
Thank you for the very nice introduction, sir. Good evening, respected chairs, distinguished guests, fellow speakers, and all the research enthusiasts present in the room. Namaste, I am Amsu Dakal. I am a researcher based at Monmouth Memorial Institute of Health Sciences under Nepal Federal Health System Project. And On behalf of my team, today I'm here to present on implementation bottlenecks for evidence-informed decision-making in Nepal's federal health system and inter-level participatory policy analysis. And this research explores why, despite having evidence, we have not been able to use it in decision-making. So these are the highlights of today's presentation. With transition to federalism, Nepal restructured its health system to improve responsiveness, equity, and access to health services. As a result, the decision-making authority has also been decentralized, and hence the province level has been enabled to develop the context-specific health policies at the province level, and it also encouraged the local government to improve and innovate in health service planning and management. While this created opportunities for the context-specific solutions, it also created challenges in coordination across different levels of government. A research in 2016 reported that despite increasing availability of evidence in Nepal, it has not been consistently utilized in decision-making due to various challenges, and the challenges listed were instability in leadership and administrative roles, the limited interaction between researchers and policymakers, and the third one was the low reading and use of research evidence among the decision makers due to busy schedule among them. Hence, this study aims to identify the implementation bottlenecks that limit the use of evidence in decision making across levels of government in Nepal's federal health system. Now, talking about the methodology, this is a qualitative research conducted in 2024. Here we use the participatory policy analysis approach, which was conducted in Lumini and Bagmati provinces selected purposively. Under these provinces, we selected rural and urban level stakeholders, that is from Bagmati, Kathmandu Metropolitan City, Chautara Sanga Joggadi Municipality, Pachpokhari Rural Municipality, and from Lumini province, we selected Ramgram Municipality and Susta Rural Municipality, and there were total 38 stakeholders involved in those workshops. And for this approach, we use the participatory tools, which is used under the participatory policy analysis workshops, which is a common approach used in health policy and system research. The first participatory tool used is River of Life. Similarly, the second tool is brainstorming and prioritization exercises and the problem tree analysis. And we conducted these workshops, and after we collected data through these workshops, we did the thematic analysis using inductive approach. I would like to share a brief about the participatory policy analysis approach. It is important because it moves beyond the traditional top-down policy process, which often overlooks the local realities, and this type of approach creates the space for diverse voices and to know about the local realities. And this approach also provides a platform for collaborative learning and also the shared problem solving involving different government level stakeholders. Now I'd like to share about the activities conducted under this approach, the PPA approach. The first one is River of Life, where the participants reflected on their journeys, the professional experiences as a result of federalization. The second is brainstorming and prioritization exercises, where the stakeholders from the local and province level identified the key challenges and bottlenecks, implementation bottlenecks that hindered the use of evidence in decision making. And this activity helped us to narrow down the most critical implementation bottlenecks for deeper analysis, as they also prioritized those challenges. And the third one is problem tree analysis approach, where the stakeholders involved in those workshops identified the root causes and the impact of those challenges, and it also helped us to know about the drivers who can influence change and how participants and researchers can support in policy action as well. So hence this PPA approach, the participatory policy analysis approach, helps us to answer where to intervene. Is it the root causes, that is on the roots or the branches where we need to act, and similarly to identify the key actors like who can drive change, and it also helps us to know about role of the participants and role of research teams as well. Now I'd like to share the key findings from this research. The first, we through the stakeholder experience identified 4 key implementation bottlenecks. The first one is ambiguity in roles and coordination. Though we have Public Health Act and regulation, but the stakeholders still experience unclear and overlapping mandates across different levels of government, which creates confusion in decision making, so they cannot use those evidence in decision making. The second one is weak intergovernmental coordination. Since we have limited structure mechanism for the communication between different levels of government, so and there is no poor sharing data practice, and that results in the fragmented planning and also the parallel decision-making processes among different levels of government. And the third one is local capacity gaps, where many stakeholders, especially from the local level, are not capacitated in data analysis and interpretation practices. So that creates, though the evidence is available, they cannot use it in decision making. And the fourth one is routine-driven resource allocation. These have been strongly shared by the stakeholders presented in those workshops. As we have budgeting based on historical pattern, administrative practices that is not aligned with the local needs and evidences available, hence that leads to geographic inequities and service delivery gaps. So to conclude, the main problem is not lack of data, but our systemic issues and challenges, the implementation bottlenecks that constrains it from using. So this research recommends 5 key recommendations, that is to clarify roles and responsibilities across levels of government, to strengthen the intergovernmental coordination mechanism, to build the local capacity so that it enables us to use the evidence effectively, to institutionalize the participatory policy analysis approaches into the routine planning and review process, and lastly, to promote evidence-driven planning and budgeting, ensuring decisions are responsive to local needs and context. The key takeaway message from this research is building better connection between people, process, that is system, and evidence, which is essential for improving the health system performance and as a whole strengthening the evidence-informed decision making. So at last, I would like to acknowledge NHRC Summit and the organizing team for providing us this opportunity to present our work. Our sincere thanks to all the stakeholders from local and province level for the time and experience shared. We are grateful to the funders for the financial support, and I am personally always glad to be part of Nepal Federal Health System project team, which is Nepal UK Collaborative Research Project. Thank you for your kind attention, and I look forward to your questions. Thank you, cheers. Thank you all.
Thank you, thank you. Maybe you can stay here, and I request all the presenters to come forward. I'll first take any questions from the participants. If there is a pressing question, please. And your question should say to whom you have a question. Please. Sudarshanji.
Thank you, sir, recognizing my name. म सुदर्शन शर्मा आइसिटी क्षेत्रमा छु विगत 15 वर्षदेखि। मेरो क्वेसन चाहिँ मन्त्रालयको सरसित थियो, म यहाँ देखिरहेको छैन। एनिवे तर पनि क्वेसन चाहिँ रेज गर्छु अहिले। यो मन्त्रालयले चाहिँ जुन इनिसिएटिभहरू लिएको छ धेरै नै राम्रो छ है, तर यहाँनिर चाहिँ यो इनिसिएटिभको पछाडिपट्टि यो इनिसिएटिभहरू सस्टेनेबल बनाउनुको लागि के कसरतहरू भइरहेछ, किनभने चाहिँ धेरै जस्तो प्रोजेक्टहरू धेरै जस्तो यो प्रोजेक्ट बेस्ड हुन्छ। त्यो प्रोजेक्ट बेस्ड हुँदाखेरि सर्टेन टाइमसम्ममा चाहिँ त्यो कन्टिन्यू हुन्छ, तर पछि चाहिँ त्यो कन्टिन्यू नहुने। फर इक्जाम्पल एउटा मैले डमी इक्जाम्पल लिएँ, एउटा रेपोजिटरी कसैले बनाउनु भयो, 5 वर्षसम्म त्यसको फन्डिङ आइरहेको थियो, अनि त्यो 5 वर्षपछि त्यो रेपोजिटरी बनाउने त्यसमा डेभलपमेन्टहरू जुन खर्च भइरहेको थियो होइन, त्यो रेपोजिटरी बनिसकेपछि त्यसलाई चाहिँ अपरेसन मेन्टेनेन्सको लागि 5 वर्षपछि त्यो लेट चाहिँ फन्डिङ बन्द भयो भने चाहिँ त्यसपछि त्यसलाई कसरी अपरेट गर्ने भन्ने मेबी प्रब्लम आउन सक्छ। मैले एउटा इमेजिनेरी एउटा इक्जाम्पल दिएको हो। त्यसरी नै जस्तै हेल्थ आइडीको जुन बनाउनु भएको छ त्यसको पछाडिपट्टि कुनै ब्याकिङ कमिटिजहरू बनाउनु भएको छ, या त्यसको अपरेसन मेन्टेनेन्सहरूको लागि सस्टेनेबल बजेटिङहरू कसरी गर्ने, के प्लानहरू छ, त्यो चाहिँ एउटा जिज्ञासाको विषय भयो। धन्यवाद।
थ्याङ्क यू सुदर्शनजी। मन्त्रालयको हाम्रो सुरज प्रकाश हरियालजी हुनुहुन्छ भने प्लिज रेस्पोन्ड गर्नुहोस्, होइन भने यो क्वेसनलाई सुरजजीको लागि हाम्रो गुणराज साहबले लिएर जानुहुन्छ, पछि तपाईँलाई लिखित जवाब मन्त्रालयमा त्यहाँ प्रेसिङ कुनै च्यालेन्जेस आयो होला, उहाँ जानु पर्यो होला। यो तपाईँको क्वेसन चाहिँ गुणराज साहबले मन्त्रालयकै भएको हुनाले यु विल क्यारी द्याट एन्ड यु विल रेस्पोन्ड टु यु।
नमस्ते, थ्याङ्क यू सर। मेरो नाम सम्झिनु भएछ, सरको मेमोरी पावर मैले एकदमै एप्रिसिएट गरेँ। आई थिङ्क मैले नेपाली, उहाँले स्विच टु नेपालीमा गर्नुभयो, म पनि अब मेरो माइन्ड नेपालीमा गइसक्यो। ओके, होइन अब सबैको प्रेजेन्टेसन एकदम राम्रो छ। अब मात्र यो एनएचआरसीलाई के बाध्यता थियो कुनै, अब डिजिटल हेल्थ र एआईको दुईवटा फरक सेसन गरे भए अझ यो हामी सुन्ने मान्छेहरूलाई पनि सबै कुरा सम्झेर बस्न सजिलो हुन्थ्यो। अब धेरैजना प्रेजेन्टेटर भएपछि एकदम यो सम्झिन गाह्रो हुँदो रहेछ कि। अब मलाई विशेष सोध्न मन लागेको चाहिँ जस्तै तपाईँले अब धेरै कुराहरू प्रेजेन्टेसन गर्नुभएको थियो। एउटा चाहिँ मलाई ठ्याक्क अहिले सम्झेको चाहिँ त्यो पेस्टिसाइड चेक गर्ने सर्टन प्रेग्नेन्सी टेस्ट जस्तै एउटा किटको कुरा गरिरहनु भएको थियो नि तपाईँले। अब त्यहाँ तपाईँको प्रेजेन्टेसन गर्दा एज फार आई अन्डरस्टुड होइन के बुझ्यो भने त्यो तरकारी घरमा किनेर लगेपछि लिटमस टेस्ट जस्तो केही गर्ने, प्रेग्नेन्सी टेस्ट जस्तै केही सोध्ने किट युज गरेर अब पेस्टिसाइड युज भएको छ भने नखाने त हो नि होइन, अब छ भने चाहिँ के गर्ने भन्ने क्वेसन भयो। कम्प्लिकेसन चाहिँ के भन्यो भने अब किनेर लैसकेको छ, कस्टमरको पैसा परिसकेको छ, यदि त्यो पेस्टिसाइड त्यहाँ छ भने चाहिँ अब त्यहाँनिर त्यो एजेन्सी भन्ने एउटा ह्युमन कस्टमरले भोइस साइलेन्ट गर्ने हो कि अब अगाडि बोल्ने हो कि, अथवा यसरी चाहिँ तरकारीमा पेस्टिसाइड यत्रो मिसाइरहेको छ। अहिले गभर्मेन्टको अफिसियल पोलिसी नै आइपिएम छ, इन्टिग्रेटेड पेस्ट म्यानेजमेन्ट। कृषि मन्त्रालयले नेपाल टेलिभिजन मार्फत यस्तो सिरियल बनाइरहेछ कि जहाँ पेस्टिसाइड युजै गर्ने भनेको छ गभर्मेन्टले। अब यस्तो केसमा अब इन्डिभिजुअललाई हामी एउटा यस्तो डिजिटल टेक्नोलोजिकल अथवा एआई ड्रिभन चाहिँ नि एउटा इम्पावरमेन्ट गर्दैछौँ कि अब हामी इन्डिभिजुअल लेभलमा चाहिँ त्यो टेस्ट गर्न सक्ने बनाउँदैछौँ भनेपछि यसमा तपाईँहरूले यस्तो टेक्नोलोजिकल कुराहरू सोचिरहँदाखेरि चाहिँ अरू एथिकल पार्टहरू, लिगल पार्टहरू पनि सोच्नुहुन्छ कि हुन्न, यसको इम्प्लिकेसन कसरी हुन्छ एउटा सोध्न मन लाग्यो। सर म अर्को एउटा दुईवटा मात्र है, अनि एलिसालाई सोध्न मन लाग्यो चाहिँ जस्तै अहिले पछिल्लो समयमा एआईको डेभलपमेन्टले चाहिँ एआई चाहिँ मोर ह्युमन हुँदै जाने, मोर इमोसनल हुँदै जाने, अनि हामी ह्युमनहरू चाहिँ मोर त्यो आर्टिफिसियल हुँदै गएको अधिकांश रिसर्च प्रेजेन्टेसनमा पनि देखिन्छ, उसमा यो अरू चिन्तन मननमा पनि देखिन्छ। जस्तै अरूहरूको त रिसर्च प्रेजेन्टेसन आफ्नो ठाउँमा छ, म धेरै गइनँ, म एउटा एलिसाजीको मैले पिकअप गर्न खोजेको। जस्तै ह्युमन सेन्ट्रिक डिजाइनमा एलिसाजीले फाइनलमा गएर कल्चरली एप्रोप्रिएट हुन्छ यो पार्टिकुलर भन्नुभयो। अब बिचमा ओभरअल चाहिँ नि जति पनि ठाउँमा तपाईँले कन्सेप्चुअल इम्पेरिकल कुराहरू गरिरहनु भएको थियो, कल्चरको पाटो फाइनल अब स्लाइडमा गएर चाहिँ यो चिज कल्चरली एप्रोप्रिएट पनि हुन्छ भन्दा जुन चिज कल्चर भन्ने भेरिएबल नै त्यहीतिर ओभर्टली तपाईँले प्रेजेन्ट गर्दा भनिरहनु भएको छैन भने कन्क्लुजनमा चाहिँ सडनली कल्चरली एप्रोप्रिएट भन्दाखेरि त त्यो त अलिकति हामीलाई चाहिँ अङ्ग्रेजी बुझेनछौँ कि कतै जस्तो महसुस हुँदो रहेछ होइन। त्यसले गर्दाखेरि एउटा त्यो अनि त्यो उनी के अब ह्युमन सेन्ट्रिक डिजाइन भनेको छ त्यो पार्टिसिपेटरी एक्सन रिसर्चकै एउटा मोडल हो नि त त्यो होइन, त्यो जति नै भने पनि भनेपछि पार्टिसिपेटरी एक्सन रिसर्चमा ह्युमन सेन्ट्रिक मोडलमै ह्युमन हराइरहेछ क्या। अब हाम्रो अंशु म्यामको पनि एउटा अलिकति छोटो होइन। अब सिम्पल त्यो नेपालमा फेडरलाइजेसनको डिबेट सबैलाई थाहा छ, यो कर्मचारी समायोजनमा समस्या भयो, कयौँ सिनियर डक्टरहरूलाई गाउँपालिका लेभल वडा लेभलभन्दा उसमा बसेर इम्पेरिकल नुएन्सेसहरू यति धेरै त्यो संहितामा गइसकेपछि हाम्रो स्वास्थ्य प्रणालीले भोग्यो कि होइन। अब प्रेजेन्टेसन हाम्रो अंशु म्यामले एकदम राम्रो प्रेजेन्टेसन गर्नुभयो, सब कुरा भयो, तर मैले चाहिँ सबै रहँदाखेरि एभिडेन्सको कुरा भयो, तर एभिडेन्स चाहिँ खोइ त फेरि एउटा मात्रै होइन। अब त्यो कन्सेप्चुअल एपारेटसको कुराहरू एकदम राम्रो चाहिँ नि इङ्ग्लिसमा फ्लुएन्सी बनाएर विथ अ प्रपर अमेरिकन एन्ड ब्रिटिस एसेन्ट एभ्रीबडी क्यान आर्टिकुलेट क्या इन दिस काइन्ड अफ कन्टेक्स्ट एन्ड सिचुएसन, बट एभिडेन्स के यो म एनएचआरसीको 2 साल पछि आएको, मलाई 2 साल मैले ग्याप गरे पनि वान अफ द रिजन्स चाहिँ अननेसेसरी पावर पोइन्ट डिस्प्ले र यो अननेसेसरी इभिडेन्स इम्पेरिकल नुआन्सेसहरू चाहिँ तपाईँ पब्लिकबाट पुरै डिप्रोफेसनलाइज डिकन्टेक्चुलाइज गर्दै लगिरहनु भएको छ। अनि तपाईँको यहाँ कम्पिटिसन चाहिँ कस्तो यो चाहिँ पब्लिक हेल्थको इभिडेन्स प्रेजेन्ट गर्न होइन, इम्पेरिकल ग्याप प्रेजेन्ट गर्न होइन, हामी पब्लिक हेल्थको चासै छैन, हामी चाहिँ कम्पिटिसन के गरिरहेको छौँ, हामी ओरेटरी स्पिच हामी इङ्ग्लिस बोल्न सक्छौँ भनेर ओरेटरी स्पिचमा कम्पिटिसन गरेर जस्तो फिल भइरहेछ क्या। यसले एभ्रिवेयर म नेपालमा मेरो प्रेजेन्टेसन छ शुद्ध नेपालीमा प्रेजेन्ट गर्छु तर मैले इन्टरनेसनल्ली त्यही प्रेजेन्टेसन युएसमा गरेर आएको मैले नेपालीमा प्रेजेन्ट गरेँ होला त कन्टेक्स्ट हुन्छ म्याटर हुन्छ जहाँ बोल्नै पर्छ तपाईँलाई अङ्ग्रेजी सुखै छैन तपाईँको जुसुकै लेभलको होस् तर बोल्नुहोस् अङ्ग्रेजी केही छैन होइन हामी पनि एप्रिसिएट गर्छौँ तर वाट्सएप इम्पेरिकल नुवान्सेस भने के खोइ त अनि अलिकति हामी रिसर्चरहरू चाहिँ हामी के को प्रेजेन्ट गरेर आएको छौँ के अब 10 मिनट फेडरलाइजेसनको कुरा सुन्दाखेरि हामी कन्सेप्चुअल एकदम राम्रो प्रेजेन्ट गर्नुभयो कन्सेप्चुअल टुलहरू पनि आयो ठिक छ तर एउटा कुरा नयाँ इन्डिकेटर त्यत्रो अनि अधिकांश यो कोल्याबोरेटिभ रिसर्चहरूमा चाहिँ त्यो देखिया छ एउटा कुरा लास्टमा एउटा भनेर टुङ्ग्याउँछु यो हामी टिचरहरूले चाहिँ स्टुडेन्टको रिसर्चमा गएर झुन्नेर फुर्को हालेर सेकेन्ड अथर थर्ड अथर भएर कति ठाउँमा त फर्स्ट अथर पनि भएको छ यस्तो अनएथिकल काम गरेर छोड्नु पऱ्यो कि अधिकांश त्यहाँ अहिले पोस्टर प्रेजेन्टेसन पनि हेरेँ त्यहाँ कति ठाउँमा हेरेँ यहाँ पनि अहिले प्रेजेन्टेसनमा टिचरहरूले नाम झुन्नाएको छ सबै आफू रिसर्च गर्ने नभए संसारमा सबै मान्छे रिसर्चर बन्नु पर्दैन राम्रो टिचर पनि पुग्छ यो अनएथिकल काम मानिन्छ स्टुडेन्टको रिसर्चमा झुन्नेर पब्लिस गर्ने कुरा चाहिँ
थ्याङ्क यू सचिनजी म आउँछु तपाईँ कहाँ यो हामी सबैलाई लेसन चाहिँ के हो भने सचिनजीले जसले जे गरे पनि आई होप यु अन्डरस्ट्यान्ड अ लिटल बेट जसले जे गरे पनि आखिरमा सोसाइटीले नलियो भने तपाईँ जतिसुकै ठुलो डाक्टर भए पनि काम छैन भन्ने सचिनजीको समरी चाहिँ थियो हो किनभने आई नो हिम एज अ इथिसिस्ट सोसियोलोजिस्ट एन्ड अ मेडिकल एन्थ्रोपोलोजिस्ट यो कन्टेक्स्ट चाहिँ उहाँले जे उठाउनु भएको छ त्यो सन्दर्भमा तपाईँलाई एप्रिसिएट गर्दै किनभने सोसाइटीले चेन्ज चाहेको थियो कुनै गतेमा चेन्ज भयो त्यो भिन्नै कुरा हो अब एआईले त्यो गतेमा चेन्ज गर्ने हो कि एआईले चेन्ज गर्ने हो अब हामी सबै प्रेजेन्टर्सको सुनौँ क्वेसनमा थ्याङ्क यू
धन्यवाद आई अपोलोजाइज श्रुति आल बी टेकिङ दिस क्वेसन इन नेपाली अधिकांश म नेपालमा दिँदाखेरि नेपालीमै बोलेर हुन्छु सोध्थेँ पहिले अनि यहाँ चाहिँ उहाँ भएर मात्र हो तर ठिक छ जुन पेस्टिसाइडको यो विषादीको समस्याको कुरा गर्दाखेरि जहिले पनि मैले भन्ने गरे चाहिँ हाम्रो सामाजिक सांस्कृतिक अथवा बहुआयामिक समस्याको समाधान चाहिँ प्रविधिले टक्क दिने होइन प्रविधि सहायक हुने हो होइन अनि यो पनि बहुआयामिक समस्या हो हाम्रो बुझाइ यसको विषादीले गर्न सक्ने हानिको बुझाइ एउटा पाटो छ अर्को व्यापारीहरूलाई अथवा कृषकहरूलाई आफ्नो बचाउनु पर्ने र छिटो त्यो व्यापार गर्नुपर्ने होइन जीविकोपार्जन गर्ने पाटो छ भने नियामक निकायहरू राज्य र नियामक निकायहरूले त्यसलाई सहज रूपमा नियमन गर्न सक्ने पाटोहरू विभिन्न पाटोहरू छ हाम्रो दृष्टिकोण चाहिँ यो खालि अब भन्दाखेरि व्यक्तिले आफ्नो भान्सामा आएर गर्न सक्छ भन्नुको चाहिँ त्यहाँ शब्द इम्पावरिङ भनेर मैले प्रयोग गरेको थिएँ भनेको हामीले त्यो सहज रूपमा परीक्षण गर्ने क्षमता अभिवृद्धि गर्न सकियो भने त्यसले त्यो फेरि व्यक्तिमा परिवारमा मात्र हुन परेन त्यसको अर्थ जस्तो मानव कसैले चाहिँ अर्ग्यानिक फार्मिङ भनेर होइन अनि यो जसरी प्राङ्गारिक खेती भन्छौँ अनि गरेर चाहिँ लिएर आयो भने अब मानव कृषकहरूले लिएर आयो कुनै एउटा बजारमा एउटा पसलमा चाहिँ बेच्न बसेको छ भने उसले पनि त त्यहाँ परीक्षण गर्न सक्ने उसलाई क्षमता भयो भने उसले चाहिँ सही कुन यो भनेर हेर्न मिल्यो होइन अथवा राज्यले नै एकदम धेरै ठाउँमा चाहिँ व्यापक रूपमा हामी परीक्षण सहज रूपमा गर्छौँ भन्नलाई यसले सहज भयो नत्र स्पेक्ट्रोमिटरहरू महँगो चिजहरू हेर्नलाई अरू सार्वजनिक समस्याहरू छन् अर्को अब व्यक्तिहरूले आम पब्लिकले पनि हामीले परीक्षण गर्न सक्ने भइसकेपछि हामीले एभिडेन्स दिन सक्ने भएको चाहिँ प्रमाण दिन्छ ल हेर है होइन एउटा निश्चित ठाउँमा हामीले गर्दा यति आइरहेछन् अहिले सामाजिक सञ्जाल जसरी प्रयोग हुन्छ त्यो ठाउँमा त्यो गर्ने भएपछि त्यसले पनि दबाब दिन्छ राज्यलाई अथवा नियामक निकायहरूलाई हामीले यति भेटाइरहेछौँ भनेर प्रमाण दिन सकेपछि सो हामीले हेरेको चाहिँ त्यो प्रविधिले त्यस्तो चिजहरू गर्न र यो सामाजिक अथवा जुन अरू होइन कानुनी रूपको समस्या छ बहुआयामिक त्यसलाई एउटा महत्त्वपूर्ण टेवा दिने भयो समाधान गर्नको लागि त्यसै हस् धन्यवाद
टार्गेटेड भन्दा पनि यस्तो सर थ्याङ्क यू हजुरको कन्सर्नको लागि मैले सायद 2-3 वर्ष अगाडि सरसँगै स्टेज पनि सेयर गरेको थिएँ ओरल प्रेजेन्टेसनको बेलामा एनएचआरसीमा ल्याङ्ग्वेज त्यस्तो प्रब्लम नहुनुपर्ने हो जस्तो लाग्छ फर मी है किनभने इङ्ग्लिस ग्लोबल ल्याङ्ग्वेज हो सो होइन सुरुमा चाहिँ त्यो आएको थियो सर सो थ्याङ्क यू फर द कन्सर्न या सो हजुरले राइट हजुरको आफ्नो एक्सपर्टिज अनुसार चाहिँ त्यो कल्चरली अप्रोप्रिएट भन्ने कुरा पनि स्वाभाविक नै हो सो 10 मिनटको प्रेजेन्टेसनमा आएर होइन त्यो एन्टायर मैले जुन देखाएको छु नि 9 मन्थ अफ प्रोसेसमा त्यो को डिजाइनिङ पार्टिसिपेटरी अप्रोच भनेको एकदम कम्प्रिहेन्सिभ मेथड हो सो त्यसमा हामीले जसरी जसले टुल नै युज गर्नुहुन्छ होइन डिफ्रेन्ट 4वटा डाइमेन्सनबाट पार्टिसिपेन्टहरू इन्भल्भ गरेर त्यो टुल डेभलप गर्नको लागि जुन हामीले मेथड युज गरेको थियौँ त्यो आएर यहाँ अब कुनै एउटा कन्क्लुजन या 10 मिनट्सको प्रेजेन्टेसन द्याट वुड नट बी फेयर एनफ जस्तो लाग्छ
थ्याङ्क यू भयो तपाईँको रेस्पोन्स म हात उठाएको देख्दैछु आनन्द वल्लभ जोशी सर प्लिज इफ यु हेभ एनी क्वेसन्स सर
This is the honestly that this is the first time that I'm having this formal class for AI, and your scientists I think they can contribute globally now. That is one. Just my small comment that this shouldn't be happen that हाम्रो human creativity चाहिँ घट्दै जाओस् र उहाँले कमेन्ट गर्नुभयो मेसिनको क्रिएटिभिटी बढ्दै जाओस् होइन हाम्रो जेनेरेसनमा इट्स अ भेरी गुड टु युज द एआई धेरै जस्तो डक्टर्सहरूको बेसिक फन्डामेन्टल्स इज भेरी गुड डक्टर रवा थापा सी इज वेल ट्रेन्ड अप्थोलोजिस्ट सी क्यान युज द होइन तर के भने फ्युचरमा हाम्रो प्रोफेसनलहरू चाहिँ मोर टुवर्ड्स द एआई र थ्योरिटिकल ब्याकअप र त्यो सब्जेक्ट कन्टेन्ट्समा त्यति एक्सपर्टिज भएन भने चाहिँ द्याट विल बी अ डिजास्टर अदरवाइज भेरी गुड प्रेजेन्टेसन थ्याङ्क यू सो मच
थ्याङ्क यू सर आम्सु एनिथिङ टु कम्प्लिमेन्ट छ भन्नु छ
हजुर थ्याङ्क यू फर द क्वेसन सचिन सर मैले रेस्पोन्ड गर्दाखेरि चाहिँ सरको क्वेसनलाई रेस्पोन्ड गर्दाखेरि चाहिँ खास यहाँ मैले प्रेजेन्ट गरेको इम्प्लिमेन्टेसन बोटलनेक्सहरू सबै स्टेक होल्डरको एक्सपिरियन्स जुन हामीले पार्टिसिपेटरी पोलिसी एनालाइसिस अप्रोच र 3टा टुलहरू युज गरेर हामीले गऱ्यौँ त्यसमा मैले यो प्रेजेन्टेसनमा चाहिँ भर्बेटिमहरू राखेन यो चाहिँ सोल्ली पार्टिसिपेन्ट्सको भर्बेटिमको आधारमा चाहिँ प्रेजेन्टेसन यो एनालाइसिस भएको हो र मैले प्रेजेन्ट गरेको हो सो यो इम्पेरिकल डेटा भन्दा पनि पार्टिसिपेन्ट्स र स्टेक होल्डर्स 2टा प्रोभिन्स र लोकल लेभलको स्टेक होल्डर्सको भर्बेटिमको आधारमा उहाँहरूको एक्सपिरियन्सको आधारमा प्रेजेन्ट गरेको हो यति नै रेस्पोन्ड हजुर यसमा अब एउटा इक्जाम्पल मैले हजुर यसमा एउटा इक्जाम्पल दिन चाहेको चाहिँ कोअर्डिनेसनको कुरा गर्दाखेरि कतिजना सदस्य हुनुहुन्थ्यो पालिकाको सदस्य कार्यपालिकाको सदस्यहरू जसले चाहिँ त्यहीँको लोकल इलेक्टेड रिप्रेजेन्टेटिभ्सहरूलाई चाहिँ कुनै पनि प्लेटफर्ममा भेट्नु भएको थिएन सो हाम्रो एउटा पिपिए अप्रोचमा चाहिँ इन्टर लेभल पार्टिसिपेटरी पोलिसी एनालाइसिस गरेर चाहिँ उहाँहरूले फर्स्ट टाइम उहाँहरूसँग कोअर्डिनेसन गर्ने इन्टरेक्सन गर्ने एउटा प्लेटफर्म पाए भनेर पनि सेयर गर्नुभएको थियो त्यो भर्बेटिमहरूमा पनि छ त्यो हाम्रो प्रेजेन्टेसन्सहरूमा पनि डेटामा पनि सो यसरी नै मैले रेस्पोन्ड गर्न चाहे हस्
थ्याङ्क यू सो मच लगभग हामी अन्त्यतिर आइसकेका छौँ प्रश्न पनि अब धेरै छैनन् होला होइन प्रश्नलाई बिट मारौँ आई थिङ्क वी हेभ 11 presentations first of all on behalf of both of we chair congratulate you all for your very nice work and presentation here especially the Professor Shruti Patil, you came to Nepal and presented on AI. This is a very new topic and your presentation is quite interesting as well. And I didn't see any questions to you from the participants, audience. हाम्रो 11वटा प्रेजेन्टेसनहरूमध्ये 6 चाहिँ इन्भाइटी प्रेजेन्टेसनहरू थिए स्पिकरहरू हुनुहुन्थ्यो र 5 चाहिँ होइन सेलेक्टेड पेपर्स जसले एप्लाई गर्नुभएको थियो यो समिटको लागि र सेलेक्टेड पेपरहरू थिए सबैले आफ्नो वर्कलाई यहाँ राम्रोसँग चाहिँ प्रेजेन्ट गर्नुभएको छ र हाम्रो थिममा सम्भवतः सरले भन्नुभएको चाहिँ अलिकति मिक्सअप टाइपको थिम छ कि किनभने सायद त्यो टाइम म्यानेजमेन्ट होइन मल्टिपल सेसनहरू प्यारलल सेसन कतिवटा गर्ने भन्ने कुराले पनि असर गरे जस्तो देखिन्छ एआई हेल्थ टेक्नोलोजी एन्ड इनोभेसन भनेको छ होइन सायद अ काइन्ड अफ आउटलायर प्रेजेन्टेसन होइन वर्क चाहिँ अंशुजीको थियो यसमा चाहिँ होइन सायद यसँग कुरा कतै मिल्दैन मोर पोलिसी एनालाइसिस छ होइन तपाईँले चाहिँ क्वालिटेटिभ होइन पर्सपेक्टिभहरू चाहिँ ल्याउनु भएको छ होइन। नभए चाहिँ धेरै जसो चाहिँ हाम्रो एआईमै हामी बढी कुरा गऱ्यौँ। अब एआईमा सबैभन्दा म आफू चाहिँ मेरो सुरुमा इन्ट्रोडक्सनमा चाहिँ मलाई एक्टिभ युजर अफ एआई र स्ट्राटेजिक एआई युज इन हेल्थ होइन त्यो सिक गर्ने होइन होइन मन्त्रालयमा बस्ने एउटा चाहिँ होइन अफिसियलको रूपमा मलाई चाहिँ इन्ट्रोड्युस गर्नुभएको थियो। मलाई के लाग्छ भने हामीलाई सधैँ एउटा रिस्क एजम्सन चाहिँ भइरहेको छ। नयाँ टेक्नोलोजीहरू आउँदाखेरि रिस्क एजम्सन हुन्छ होइन। हरेक मेसिनहरू हामीले चाहिँ फिजिकल होइन वर्कको लागि मेसिनहरू प्रयोग गर्थ्यौँ। पछि गएर कलर केयर कामको लागि चाहिँ हामीले मेसिनहरू युज गऱ्यौँ। क्यालकुलेटरदेखि लिएर कम्प्युटरदेखि युज गर्दै गयौँ होइन। त्यसले यी सबै मेसिनहरू प्रयोग गर्दै अहिले त यति धेरै मेसिनहरू, एकैछिन एआई छोडौँ, इन्टेलिजेन्स भएका कुराहरू गऱ्यो भने हामी all are advancing. We became very much advanced and modernized due to use of machines. होइन अब युज अफ मेसिन्स कति चाहिँ होइन त्यसको नराम्रा पक्ष छन् होइन, कति चाहिँ राम्रा पक्ष छन्। मेडिकल एन्थ्रोपोलोजिस्टहरू हुनुहुन्छ हाम्रो होइन यो के अरे एन्थ्रोपोलोजिकल पोइन्ट अफ भ्यूबाट यसले कति चाहिँ प्याराडाइम सिफ्ट गरेको छ त्यो अर्कै पाटो होला होइन। तर हामी जति धेरै हाम्रो नलेजलाई हामीले ह्युमन नलेजलाई हामीले प्रिसियस मान्छौँ पनि होला, किनभने ह्युमनले होइन विश्वलाई कन्कर गरेको होइन थाउजन्ड्स इयर भएको छ होइन। त्यस कारणले यसैले यो नलेजकै कारणले भएको छ। त्यस कारणले हाम्रो नलेज कतै अर्कोले लैदिन्छ कि भन्ने डर हुनु स्वाभाविक हो, त्यो एउटा रिस्क एजम्सन हो जस्तो लाग्छ। तर हामीले कतिपय डेली, जस्तै मैले युज गर्ने चाहिँ एआई के भने डेली कलरिकल जबमा मैले युज गर्छु होइन। त्यसले मेरो टाइम वायत खाइदिएको थियो। तर अहिले चाहिँ त्योभन्दा बढी एक्स्ट्रा सोच्न सक्छ नि, अरू कुराहरू सोच्न सकिन्छ होला होइन, फर्दर सोच्न पनि अपर्च्युनिटी दिन्छ होला। त्यसरी पनि हेर्नु छ, अपर्च्युनिटी पनि छ, रिस्क पनि छ होइन। त्यो हिसाबले चाहिँ हामी हेर्नुपर्छ जस्तो लाग्छ। अनि झन् स्मार्ट पनि हुनसक्छ। कति प्रेजेन्टेसनहरूमा हामीले एआईको युज इन हेल्थमा होइन, जस्तै एक्सरेको रिडिङ होइन, एमआरआई सिटीको रिडिङ मोर एकुरेट भएको होइन, त्यसको सेन्सिटिभिटी, त्यसको स्पेसिफिसिटी बेटर देन ह्युमन हो भने त्यो पनि हामीले रिसर्च गर्न चाहिँ आवश्यक छ। फेरि त्यस्ता खालका चाहिँ होइन हामीले रिसर्चहरू, एक्सपेरिमेन्टल रिसर्चहरू गर्न आवश्यक छ। न कि होइन ऱ्याम्पेन्टली वी सुड गो फर एआई होइन होइन। त्यसको चाहिँ कति त ह्युमन इरर कति हुन्छ र मसिनको इरर के छ भनेर जानुपर्छ होला। नभए हाम्रो इमोसन कसैले लैदिन्छ क्या, आई डोन्ट नो होइन। आई डोन्ट थिङ्क हाम्रो इमोसन कसैले छोडिदिँदैन होला। हाम्रो क्रिएटिभिटी झन् धेरै राम्रो हुन्छ होला भन्ने पोजिटिभ होइन हामीले चाहिँ राख्नुपर्छ जस्तो लाग्छ। यति भन्दै सबै प्रेजेन्टरलाई र स्पेसली हजुर you have one question to Sishiva. Okay.
I was just wanting to know that what kind of in India regarding the ethical, let's say rational use of AI in terms of medical science, because recently the Britain government has AI related policy that if any filmmaker they are making a film and if they are using AI related content, then they have to mention that particular scene SGI means synthetic or SGC, synthetically generated content, so that I would really like to know the discourse and all sort of debate, especially focusing on ethical guidelines related to rational use of AI in India.
So actually in India, what is happening, initially in 2018 itself, we have rolled out an AI policy. But with the advent of Gen AI and now with the advent of agentic AI, even Indian government is still on the run to apprise that AI policy so that more of this generative AI content policing can be done. Currently, there is no standard policy which even India is following for Gen AI content. However, for medical use of AI applications, so India follows a very strict policy in terms of ethical approvals of the data that is not given very easily. And in that now they are also adding AI. So for any research organization like we have ICMR or DBT or DST, so now they have introduced AI plagiarism policy as well for all the proposals, that none of the proposal is accepted which is having any AI plagiarism. mechanism. Also, the universities has been given the mandate that all the projects, all the project reports which the students are producing has to be checked via Turnitin. So that has also come. So one unified policy is yet to come, which will, fine tune all the gaps of privacy and security of the data. However, in bits and pieces, they have already started rolling out.
That's quite interesting.
Yes.
Thank you, Shashi. So,
लास्ट एउटा विशेष चिजले एउटा लास्ट अब सकौँ नि यो एउटा मात्र अलिक छोटोमा तपाईँले एन्सर दिनुभयो हुन्छ रिसेन्टली त्यो 5 days आज जति पनि मेडिकल दुनियाँमा चाहिँ यो एआईको युजहरूको है होइन तपाईँले एउटा चाहिँ कस्तो नि फिल्ममा चाहिँ यस्तो प्याराडाइम सिफ्ट र ऊ आइसक्यो कि धेरै म्यानुअल वर्करहरू रिप्लेस लिएर त्यो लाइटको टेक्निसियनदेखि धेरै र मान्छेले एउटा ल्यापटप लिएर घरमा बसेर हलिउडसँग चाइनिज इन्डस्ट्रीसँग कम्पिटिसन गर्न सक्ने नेपालमै बसेर त्यस्तो फिल्म बनाउन सक्ने नेपालमै बसेर हुने भयो अब यसमा चाहिँ जस्तो अब हामीले एआईको जति पनि गर्दै जान्छौँ एथिकल ऱ्यासनल र युजहरू प्र्याक्टिकल युजहरू तपाईँले अहिले हेल्थ सिस्टममा चाहिँ कतिको ग्याप यो ह्युमन रिसोर्सलाई रिप्लेस गर्ला जस्तो छ पार्टिकुलर कुन ह्युमन रिसोर्स जस्तै यहाँ त अब फिल्म जस्तो आर्ट होइन यो त साइन्स हो यहाँ त कयौँ मान्छेलाई लाइसेन्सिङ नगरिकन पार्टिकुलर फिल्डमा कामै गर्न पाइँदैन त्यसले गर्दा अहिले तपाईँ आज हेर्दा चाहिँ कुन चाहिँ ह्युमन रिसोर्सलाई चाहिँ बढी यसले च्यालेन्ज चाहिँ दिइरहेको छ जस्तो फिल भइरहेको छ तपाईँ
हरेक क्षेत्रमा यसको हेलो अब त्यो फिल्म मात्र होइन हरेक क्षेत्रमा यसले त्यो मान्छेले गर्ने काम अनि जब इकोनोमी अर्थतन्त्र र कामको जुन एउटा सम्बन्ध हुन्छ त्यसलाई पुनर्वासित गर्ने सम्भावना छ होइन अब स्वास्थ्यमा चाहिँ स्वास्थ्य अलिकति फरक किन छ भने हामीले हेऱ्यौँ भने यसमा धेरै विशेष गरी विकासोन्मुख देश र विकसित भइसकेका देशमा त स्वास्थ्यको पहुँच आम नागरिक आम जनतामा सहज रूपमा सर्वसुलभ रूपमा पुगिसकेको र नपुगेको ठाउँलाई अलिक फरक तरिकाले हेर्नुपर्छ जस्तो लाग्छ होइन त्यो हेर्दाखेरि हाम्रो जस्तो देशहरूमा चाहिँ अब अफ्रिका दक्षिण धेरै देशहरू हैनमा चाहिँ अझ पनि सर्वसुलभ रूपमा पुग्नलाई फेरि पनि त्यो एउटै मात्र पाटो छैन एकदम बहुआयामिक छ डाक्टरहरू नर्सहरू जस्तो हाम्रो धेरैजना विदेश जाने अथवा अहिलेको अवस्थामा हामी काठमाडौँ अथवा निश्चित सहरहरूमा बाहेक अरू ठाउँमा नजाने हुँदाखेरि अथवा यसको जुन किसिमले चाहिँ डिस्ट्रिब्युट विकेन्द्रीकृत हुनुपर्ने हो स्वास्थ्य सेवाहरू एउटा त्यसकै समस्याहरूले गर्दाखेरि पनि एआईले चाहिँ सिधै मान्छेलाई रिप्लेस गर्ने भन्दा पनि यसलाई पुनर्वासित गर्छ होला विकेन्द्रीकरण कसरी गर्नेमा अनि सही ढङ्गले प्रयोग गर्यो भने यो चाहिँ एकदमै राम्रो भनौँ न जुन हाम्रो जस्तो देशलाई आम रूपमा मान्छेलाई सहज मुख्य कुरा गुणस्तर र सुलभ होइन र महँगो नहुने जुन स्वास्थ्य सेवा पुर्याउनुपर्छ त्यसमा ठुलो भूमिका खेल्न सक्छ एक होइन त्यो हुँदा रिस्किलिङ अपस्किलिङ चाहिँ चाहिन्छ त्यसमा हामीले धेरै काम पनि गरिरहेछौँ र मैले यो हेल्थ बाहेक अरू एआईको रिसर्च गर्दा नेपालमा मात्र संसारमा चाहिँ अब यो रिस्किलिङ अपस्किलिङ कसरी जान्छ भन्ने एउटा पेपर भर्खर हामीले लेखेका पनि छौँ यसमा चाहिँ यो प्रोग्रामेटिक समस्या मात्र होइन कि इन्फ्रास्ट्रक्चर समस्या हो होइन हामीले चाहिँ ट्रेन कसरी गर्ने आम रूपमा सोसाइटीलाई ट्रेनिङ एउटा लर्निङ भएपछि काम गर्ने र इकोनोमीसँग जोड्नेमा चाहिँ इन्फ्रास्ट्रक्चर एकदम मिलियन्स अफ पिपललाई छिटो रिस्किलिङ अपस्किलिङ गर्नुपर्छ त्यसमा इन्फ्रास्ट्रक्चर चाहिन्छ भन्ने कुरा छ एउटा त्यो हिसाबले चाहिँ अर्को चाहिँ हेल्थ केयरमा अलि लामो हुन जान्छ होला तर मैले चाहिँ तिनवटा जस्तो दुईवटा थोरै भन्छु म 1 मिनटमा यो हेल्थ सिस्टममा मान्छे जाने कि जस्तो डाक्टर कहाँ जाने हस्पिटल जाने कि आम हेल्थ सिस्टमै मान्छेमा आउने भन्नेमा चाहिँ ब्रोडर फ्रेमवर्कमा नेक्स्ट 2 दशकमा चाहिँ धेरै ट्रान्सफर्मेसन आउँछ जस्तो लाग्छ त्यसले पनि यो पुनर्वासित गर्छ त्यो चाहिँ पछि कुरा गरौँ
थ्याङ्क यू होइन एकदमै इन्ट्रेस्टिङ डिस्कसन भएको छ तर हाम्रो टाइम चाहिँ एकदमै होइन सिद्धिसकेको छ लामो समय पनि भयो अहिले भर्खरको फाइनल चाहिँ मेरो आफ्नो अब्जर्भेसन होइन हामीले सबै पहिलाका कामहरू रिप्लेसै गर्दै गयो कि अर्को नयाँ कामबाटै रिप्लेस गर्दै मोडर्नाइज हुँदै जान्छौँ पहिलाको काम हुन्छ हातले लेख्थ्यो भने टाइप गरेर टाइप लेख्थ्यो भने कम्प्युटरको रिप्लेसेबल अल रिप्लेसेबल हो तर चाहिँ कहाँनिर हुन्छ भने हेल्थ केयरमा मलाई के लाग्छ नि हेल्थ सर्भिसमा रेडियोलोजिस्टको ड्युटी आवर्स घटाउला उसको स्ट्रेस घटाउला हाम्रो ह्युमन रिसोर्सको निड घटाउला उसको जब रिप्लेस भन्दा पनि उसले आफै युज गर्छ होला त्यसलाई भन्नेतिर हामीले एजम्सन गर्न सक्छौँ जस्तो लाग्छ फुल रिप्लेसमेन्ट कि टोटल एआई घरमै बसेर एउटा चाहिँ होइन के अरे स्मार्टफोन हेरेपछि सबै चेकअप हुने त्यस्तोमा त नजाला जस्तो लाग्छ त्यो भनेको पनि हामी सबैलाई ओभरअल हाम्रो चाहिँ टाइम घटाउन खोजेको मेसिनले घटाउन खोजेको त टाइम इफिसियन्ट गराउन खोजेको सबै कुरा चाहिँ अलि मोर एकुरेट पनि गर्न खोजेको हो प्रिसाइज गर्न खोजेको हो र फाइनली म आफैलाई कस्तो लाग्छ भने वी आर अल्सो बायोलोजिकल एआई. हामी पनि बच्चादेखि ट्रेन्ड हो नि, लर्निङबाट नै हाम्रो चाहिँ ब्रेनहरू डेभलप हुँदै गएको छ. दो वी हेभ अ डिफ्रेन्ट टाइप अफ होइन के अरे कल्चरल पर्सेप्सन, इमोसनल होइन रियाक्सन्स, त्यो अर्कै कुरा भयो होइन. त्यस कारणले यो लर्निङ जस्तो मलाई लाग्छ. त्यसैले वी हेभ टु बी होइन मोर कस्टमाइज होइन एडाप्टेड हुनुपर्छ र यसमा हामी धेरै ब्याक पनि हुनुहुन्न, त्यो लाइनमा जानुपर्छ जस्तो लाग्छ. म एज अ मिनिस्ट्रीमा काम गर्ने अफिसियलको हिसाबले पनि हामी धेरै पछाडि छौँ जस्तो लाग्छ. अब गर्न सक्छ, एक्ज्याक्टली त्यो हुनसक्छ. त्यस कारणले हामी तयार हुनुपर्छ जस्तो लाग्छ. यो धेरै इन्ट्रेस्टिङ चाहिँ होइन सेसन रह्यो. यहाँहरू सबैलाई धेरै धेरै फेरि पनि धन्यवाद दिँदै होइन मलाई चेयरको रूपमा चाहिँ यहाँ अपर्च्युनिटी दिनुभएको हुँदाखेरि मलाई चाहिँ एनएचआरसीलाई पनि एकदमै म आभारी छु भन्दै म चाहिँ प्रोफेसर घिमिरेलाई ह्यान्डओभर गर्छु.
थ्याङ्क यू डाक्टर गुण, माई कोच हियर. लास्टमा म 2 मिनट टाइम लिन्छु. तपाईँहरू सबैले एभ्रिबडी हेज डन अ भेरी एक्सलेन्ट प्रेजेन्टेसन. Thank you, Professor Srishti, for bringing a perspective of more than 50 billion economy, which is being generated through AI. Our Nepal, how much we can contribute to that, how much we can export, how much we need to import. That's the challenge where we have to make a balance. And you have mentioned 87% accuracy. When I teach biosecurity, 1% error means thousands of people dying a day. So 13% error. So we still have to do many things to improve this, bringing the gap to less than 1%. So this is a challenge where I see that Bishesh and team can contribute from the country, while Dr. Rava and team can bring their people to rural health centers so that every ophthalmologist doesn't have to travel, so ophthalmic assistants and others can do a preliminary screening and the experts can sit in a better center and all people can get regular specialized services where there is need be. And Suraj Aryalji from ministry, probably what his vision, probably government funds his vision, and the digitalized health system works in next few decades, if not years. And Vishnuji being in the NHRC, what I see is NHRC is proactively working on some of the areas where it can contribute. I could see that Ramchandraji and others are supporting those who are in need of assistive technology. I really like the presentation from all others, including Sandhya, who made my Sandhya today. Ramro, evening, good evening. Very Ramro presentation too. Ani Alisa, Ranjana, Srishti, र आम्सु सबैको प्रेजेन्टेसनबाट I got a chance to learn many things. Still see there are challenges which we all together can work and reduce the gap. Thank you all for your time and presentations, and hope your contribution will be counted by Ministry and the Research Council to move forward. Thank you. I now hand over to the organizers.
Thank you so much. Wow, what an insightful session and discussion showcasing the dynamic application of artificial intelligence in the field of health. And AI, the terminologies that is no longer the future, but it is the present. We all have different perspective, but we can all agree on one point that we cannot overlook on the AI. Okay, having said that, to honor your contributions, especially to the presenters, thank you very much. And to honor your contributions, I now invite our session chairs to present the token of love. So maybe please have you on the stage, please. So as I read your name, please all the presenters come forward for the token of love. Okay. Dr. Shruti Patel, Dr. Vishesh Khanal, Mr. Suraj Prakash Aryal, Dr. Vishnu Prasad Marasini, Mr. Rava Thapa, Ms. Rava Thapa, Mr. Ramchandra Thapa, Alicia Karki, Ranjana Koirala, Sandhya Niraula, Srishti Singh, and Amshu Dakal. Please proceed forward to have your token of love. And please, can we have a round of applause, please? Okay. A very heartfelt thank you to each of you for the dedication and effort you have put in your research and presentation. Now I would like to request Dr. Hari Prasad Dhakal, Executive Committee Member of NHRC, to come on stage and present a token of appreciation to our esteemed chairs. Thank you so much. Now I would like to request to all the presenters and chairs to come together for a photograph, for a group photo. Thank you everyone. With this, we have come to an end of our today's session. Thank you everyone for being with us. Have a good evening. Thank you.